Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews, the home of the very best NCLEX review in the entire universe. In my opinion, Mark Klimek is the GOAT of NCLEX review. You can find out more about our 21-plus hour NCLEX prep course by going to clinicreviews.com. We also have a streaming service and a small group tutoring option. You can meet me live over Zoom by signing up for the small group tutoring. I do 2 of the 4 sessions. All right, so we're going to do health promotion and maintenance, risk factors, and smoking cessation today. So let's go ahead and get started. A community health nurse prioritizes outreach for which client? Community health nurse prioritizes outreach for which client? So I guess really what it's saying is who requires the community health nurse to see first. The wording may confuse you, but we're just going to say who needs the community health nurse most. 28. So it looks like we've got risk factors here. 28-year-old barista, vapes daily, runs 3 times a week. 45-year-old carpenter, 10-pack years, quit 5 years ago. 65-year-old shipyard worker, 40-pack years, still smokes. 50-year-old office worker, never smoked, BMI of 33. So what I do for risk factors, I actually count risk factors. There's not very many things on the NCLEX where I actually count things, but this is one. You count the number of risk factors. So 28 is not a risk factor. Vapes daily is a risk factor. So they've got 1 risk factor. B, 45-year-old carpenter is 45. No, I don't think so. I wouldn't really think of 45-year-olds necessarily at risk, maybe, but 10-pack years, but he quit 5 years ago. He's maybe got 1 that he's got a history of smoking. C is a 62-year-old, so I'd say 62, I'd say probably over 50, 55. I'd start thinking of age as a risk factor. 52-year-old shipyard worker. I don't know if that's a risk factor. The age is 40-pack years. He still smokes, so he's at least got 2. D, 50-year-old office worker, never smoked. I'm not going to count 50 as a risk factor. BMI is high, so normal BMI should be anywhere between, I think, 18 and 25, so he is overweight. But I would say C, I would say they all have like 1, except for C has 2. So that's the one I'm going to go with, and that is, in fact, the correct answer. All right. Which statement best shows the client is in the preparation stage to quit smoking? All right. So even if you haven't heard of the trans-theoretical model of behavior change, and it's okay if you've never heard of it, it is a changing behavior model. And there's actually 5 stages. There's pre-contemplation, contemplation, preparation, action, and maintenance. So in pre-contemplation, let's say the person is smoking. Behavior change, pre-contemplation, they're not even thinking about quitting. Like you say, are you thinking about quitting? No, I'm never going to quit smoking. Get away from me, right? That's pre-contemplation. Then contemplation is, I'm thinking about it. I don't have a plan yet, but yeah, I'd sort of like to quit maybe someday. That's contemplation. Preparation is, I have a plan. After I smoke this pack of cigarettes, I'm done. I'm never going to smoke again. That's preparation. Action is when they've made the change. They stopped smoking less than 6 months ago. Maintenance is they've quit smoking more than 6 months ago. So if they're in the preparation stage, they have a plan to quit. So we're looking for an answer that says they have a plan to quit smoking. A, smoking helps me relax. I'm fine. That's pre-contemplation. B, I know I should quit maybe someday. That's contemplation. C, I set a quit date for next Monday and bought patches. That's preparation. D, I quit last month. That's action. So we're going to say preparation. This one we were looking for is I set a quit date for next Monday and bought patches. Which instruction is priority the day a client starts a nicotine patch? All right, nicotine. So nicotine patches are good, but you can't overdo it on nicotine. Nicotine is considered a drug, and you can't overdose on nicotine. So if you're going to start a nicotine patch, you cannot smoke at the same time. You can't ingest nicotine. Like, you got to stop doing whatever it is that way you take nicotine if you take it by the patch. So this is oh no, it's not. It's a single choice answer. Okay, which instruction is a priority? So which one do I have to tell them? Continue usual number of cigarettes today to taper. No, that's the day they put the patch on, you don't continue the number of cigarettes to taper. No, false. B, place the patch on a hairy area for better absorption. Wrong. You want to put it on a hairless area. C, use heat to speed absorption if cravings occur. Heat to speed absorption. I don't know if heat would speed absorption. It might bring more blood to the area, but I don't really, I mean, I can't control how much nicotine they're getting. If I use heat to speed absorption, I could be giving them too much. That doesn't seem like a good idea. D, remove the patch at bedtime to reduce vivid dreams. That's actually true. And they have found that nicotine is whether you memorize this or not, you probably could have figured out the right answer because A, B, and C are all wrong. And I do rule out wrong answers to get to the right answer. But it is true that nicotine use patches have given vivid dreams. And, people don't usually either smoke or they don't smoke while they're sleeping. So that's why they don't normally get vivid dreams when they're smoking. So they do remove the patch at bedtime and put it back on in the morning. Now, I don't think this is going to be an NCLEX question, but in real life, this is a real life question, not an NCLEX recommendation. In real life, if people do get cravings, as long as they have to get recommendations from their physician, but they can use nicotine gum to deal with the cravings. So it is considered to be okay as long as they're under the supervision of a provider to use nicotine gum to deal with the cravings as opposed to cigarettes to deal with the cravings. Which history requires the nurse to question a prescription for bupropion sustained release for smoking cessation?
I bet 99% of people don't even know about this. Are you still using plastic bags to store your food? They're not only unhygienic, but also make your food spoil faster. Check out these aluminum foil storage bags. Just put your meat, veggies, or fruit inside, seal them up, and pop them in the freezer. Even after a whole year, the food stays perfectly fresh. They're made with the same aluminum foil material used inside milk cartons, which locks in freshness and prevents your food from drying out or going bad. The zipper-style seal keeps everything airtight and is super easy to use. Honestly, I don't even need to say more. Try it once and you'll never go back. And the best part, it's free shipping at this price. Feels like getting it for free. I've dropped the link right here. Hurry before
The NCLEX covers all the topics that took years to learn in nursing school. Now it's condensed into one fateful test. With so many concepts to learn, it's important to study the way that works best for you. We make it easy to use UWorld, your way. Tailor the study plan to match your needs and schedule. Pinpoint your challenge areas with self-assessments. Stay focused by creating practice tests that feature only your high-priority questions. Learn faster with bite-sized video lessons focused on key exam topics. Get ahead by capturing text and images as you go, making it easy to review later. All of this is available on your laptop or mobile device so you can study at school, at home, or by the pool. It's UWorld, your way.
Okay, so in our last video, actually, we talked about the difference between questioning an order and clarifying an order. Questioning an order means it could harm the patient, and I got to question it because it could harm the patient. Clarifying an order means that it was written incorrectly, and I need to clarify the dose or the route or the frequency or the drug itself because it's misspelled or something. So when it says requires the nurse to question, you say, well, which, if they have this comorbidity, could bupropion hurt them? So seizure disorder, type 2 diabetes, GERD, or mild hypertension. There are side effects to PO meds. They could have some gastric reflux, but if they're taking an oral med, they could have some GI distress, but that's not considered harming the patient. Usually we just say take it with food or something like that. So I'm going to cross off GERD. Mild hypertension, the word mild always makes me think that's okay. Like I'm just giving you an NCLEX strategy. That's all I'm saying. If the other answers were completely wrong, then I would maybe consider mild hypertension. But whenever it says mild anything, I'm like, that's probably not the answer they're looking for. So I'm kind of between seizure disorder and type 2 diabetes. And this is if I don't know. I'm teaching you how to guess. Y'all, I wrote the question. I know what the right answer is, but I'm teaching you how to guess. So if you don't know what bupropion is, it's actually also known as Wellbutrin. It's an antidepressant, But they found that when they put people on it, they had a tendency to quit smoking. So that's how they ended up using it for smoking cessation. So if I know bupropion is Wellbutrin, which is an antidepressant, I'm thinking that it could affect neurotransmitters. That's just like what I'm thinking. And so if this is a drug that affects neurotransmitters, would that be more likely to exacerbate seizure disorder or to exacerbate type 2 diabetes? And I say, well, if I'm going to just go with body systems, then I'm going to have to say seizure disorder, because seizure disorder is all about firing of the brain. And if we're messing with neurotransmitters, that could affect seizure disorder. And in fact, that's the right answer. So do I recommend that you memorize this fact? I don't, y'all. I do recommend you know what bupropion is. I do recommend you know bupropion is Wellbutrin and that it affects neurotransmitters. But I don't think you have to memorize that seizure disorder is a contraindication, because I think you can figure it out as long as you know the concepts related to the drug and the disorder. That's just my recommendation. Which client statement about varenicline, which is Chantix, needs follow-up? So this is another drug that helps with smoking cessation. So let's see what the answer is. Which client statement needs follow-up? So I'm looking for the false statement. I'm looking for the wrong statement. They said this about Chantix, and it's wrong. I'll start it a week before my quit date. Now, these oral meds like bupropion and varenicline, they can start it while they're still smoking, because it's not nicotine. They're not overdosing on nicotine. So it is appropriate to start to take the drug before you quit smoking, whether it's this one or bupropion. So that's fine. That's a true statement. Nausea is common at first. Y'all, nausea is the most common side effect just about of any oral drug. So sure, I'm sure it's a common side effect for this one too. If I feel depressed or have strange dreams, I'll notify my provider. Well, yeah, if you get depressed or have, that seems like a good idea. That seems like, okay, good. I'm glad you will. Good. I can combine it with a nicotine patch to make it stronger. No, that's not going to help. It's not nicotine, y'all. It's not a nicotine supplement at all. And especially if they're continuing to smoke, no. I mean, they may be able to combine it with a nicotine patch at some point, but they have to have quit smoking completely. These are two different drugs, and they're both used for smoking cessation, but they have totally different mechanisms of action. So you would need to correct this idea that they combine it with nicotine to make it stronger, and make sure they understand they're two different medications with two different mechanisms of action, and they need to be treated differently. A pregnant client smokes one half pack a day. What's the best initial nursing action? So we know this person really needs to not smoke, right? They're pregnant, and we really need to get them to quit. So which answer shows I know the best way to help them quit while they're pregnant? Recommend varenicline immediately. Well, varenicline, you usually have to be on it for a while before you quit. So I'm not sure that would be the best thing to do right now, immediately. Provide brief counseling and offer intensive behavioral support. So brief counseling, like, you know what, this is really dangerous for the baby. You really need to stop smoking. Let's get you into an intensive behavioral support group that can help you quit smoking. That seems like a good idea. C, suggest cutting down to 1 to 2 cigarettes a day. Well, no, they need to quit smoking. D, advise e-cigarettes as a safer alternative. It is not a safer alternative. So we need to provide brief counseling and offer intensive behavioral support. That's the correct answer. Which findings increase cardiometabolic risk? Cardiometabolic risk. So cardiometabolic risk is heart risk, heart disease, and metabolic is breaking down and using calories for energy. So we tend to think of metabolic risk as like lipids, diabetes, that kind of thing. Okay, so that's what I think of when I think of cardio. And then heart disease, so heart disease is associated with metabolic disorders like fat breakdown and glucose breakdown, which is diabetes, and hyperlipidemia. All right, select all that apply. A waist circumference of 42 inches, male. So male waists, if you don't know this is just sort of one of these, they think you know everyday information. And so I think there's probably a lot of women who don't know what the normal male waist circumference is. I don't know what's considered absolutely normal, but most men who are not overweight could probably fit into pants anywhere between 28 inches and 34 to 36 inches. Big and tall, like in the US, we have big and tall shops for men that are taller or bigger. Big and tall shops tend to start at around 36-inch pants and go up to like 54, 55, 56, right? Like, or bigger. And so 42 is into the big and tall store. And so I'm going to say that's a risk because that would indicate that they're bigger than they should be. And bigger means fatter. That's what I mean when I say bigger. HDL is 65, females. HDL is 60, that's the good cholesterol. We want it to be higher, and that's a good number. HDL of 65 is a good number. So that's the good cholesterol. Fasting glucose of 112. Okay, what is normal fasting glucose, y'all? It's 70. I usually say 70 to 110. All right, 70 to 110. So if a fasting glucose is 112, that is high. That's high. Don't say, well, it's close. No, it's high. Okay, there's a normal range for a reason. So if they have, what it's saying is they are not breaking down glucose the way you would expect them to. That's a metabolic risk factor for heart disease. So C is a risk factor. Triglycerides of 260, that's high. Triglycerides of 260, you want to be under 200, I'm pretty sure, for triglycerides. That's part of that lipid profile, right? Lipids, triglycerides. Blood pressure is normal. That's not a risk factor. So those are the cardiometabolic risks identified here in this question. Which factors place a client at increased risk for type 2 diabetes? All right, so let's just talk about it. What does put a client at risk for type 2 diabetes? Obesity, family history, those are the main things.
The truth is, not every child gets the chance to go to the movies. In North America alone, more than 20 million kids may never step inside a theater. But together, we can change that. I'm Phil Cunningham, creator of David. Our goal is to help 1 million kids experience David in theaters for free. Because when a child sees this story, it plants courage and faith that ripples into their homes, their schools, their friendships. 1 million kids inspired means an entire generation changed. Go get your tickets today for free at angel.com/David. When you get your tickets and help fill those theaters, you're helping a child experience their very first movie on the big screen. Imagine if David was that movie. Thank you so, so much.
Let's see what the options are here. BMI of 32. So I told you the BMI should be, well, maybe I didn't, but it should be anywhere between 18 and 25. So a BMI of 32 is high, which is obesity. First degree relative, that's the genetic risk right there. History of gestational diabetes. Yes, if a woman has a history of gestational diabetes, that also puts her at risk for type 2. D, HDL of 70, that's very high, that's good. That's the good cholesterol, walks 3 miles a day. No, that's not a risk factor. Exercise is good. So those are the risk factors for type 2 diabetes. Which nursing action best aligns with health promotion for a 52-year-old adult at average risk? 52-year-old adult at average risk. Okay. A, cancer screening starts at age 60. B, schedule a colon cancer screening now, age 52. C, check PSA. Colon screening isn't necessary. D, focus on BMI. Cancer screening start at age 60. Okay, well, I hope you know cancer screenings start before age 60. They start at like age 52. But you could rule out A and D because they say the same thing. So if two answers say the same thing, then neither one of them can be correct in a single choice question. So we're going to cross off A and D. And we know it starts at 50, like most of the cancer screenings. So schedule colon cancer screening now. Yes, means like a colonoscopy or something, digital rectal exam, something like that, colon rectal cancer screening, colon screening. Yes, that's a good idea. And then C, check PSA. Well, we should do that if it's a male. Colon screening isn't necessary. That's a not true statement. We would want to do the first half, but the second half is wrong. So we're not going to choose an answer that's only half right. All right, I hope that was helpful to you. Thank you for being a part of the Clinic Review family. Good luck on your NCLEX. Let me know how you do. Don't you have to go into the NCLEX with the mindset of I'm going to get 150 questions, okay? Because if you think you're going to stop at 85, then as soon as it flips to 86, you're thinking I failed. You didn't fail. As long as you're still getting questions, you're still passing, okay? So you want to make sure you go in with the intention of sitting for 150 minutes. So, and then if it stops at 85, that's great. Great job. But if it stops, I know people pass at 102, 140, 150. They pass all the time at those numbers. So don't give up, okay? All right, good luck. Thanks for being a part of our family. Hello, my friends. It's Dr. Sharon with Clinic Reviews. Today we're going to be talking about communication, just therapeutic communication. So it's going to be pretty straightforward. It's pretty fundamental. Definitely you need to know this for the NCLEX. So let's go ahead and get started. Hello, my friends. It's Dr. Sharon with Clinic Reviews. You know, Clinic Reviews is the organization that is in charge of this YouTube channel. Mark Klimek is the GOAT of NCLEX reviews. He's been doing it for 40 plus years. You can find out more about our NCLEX online on-demand NCLEX review, 21 plus hours of recorded content by the GOAT himself, Mark Klimek. Go to clinicreviews.com. And you can also sign up for our streaming service where you get all the videos we've ever made, then put on YouTube, including the ones that have been taken down just because of their age. They're all on our streaming service. You can also meet me live via Zoom if you want to sign up for our tutoring service. So, small group tutoring. All right, let's go ahead and get started. So this is our, sorry, I was just looking to see if my dogs are around. Sometimes you guys like to see my dogs, but they're all pretty chill right now, so I don't think they're going to be very happy if I ask them to get up. They are in here with me, but all right, so these are pretty straightforward, pretty fundamental communication questions. A nurse is planning a diabetes education class for a community group. Which action should the nurse take first, which means more than one could be something I would do. The question is, what would I do first? Arrange for handouts to be printed in English. Okay, fine. Assess the groups. Does anything about cross-cultural? Okay, assess the group's literacy level and language needs. Oh, well, that would be better to do that before I do A. Assess what time of day the clients prefer to hold the class. Maybe. I don't know. Usually we don't do that. Usually we assess what they know, sort of their readiness for learning. We don't usually assess what time of day the clients prefer to hold the class. Provide a demonstration of insulin injection. Well, that would be later. So the first thing I need to do is assess the group's literacy level and language needs. So that's what I need to do first. I always press the wrong button to start out with. Okay, there we go. That's what I would do first. All right, a nurse is teaching a newly diagnosed hypertensive client. Newly diagnosed hypertensive. Okay, the client appears distracted and states, I'm worried about losing my job. What should the nurse do first? Postpone the teaching session. Maybe. Provide written materials to read later. Maybe. Redirect the client back to the importance of learning. Probably not. Assess the client's readiness to learn. Yeah, I mean, what should I do first? So I have to assess the client's readiness to learn first, because then that'll decide whether I postpone the teaching or not, or redirect the client back to the importance of learning. Like I have to assess the readiness to learn before I can do either A or C. I might do B depending on, their readiness to learn and any assessment I might do. So yeah, I definitely have to do that first, because the other three I might do, but I have to know what their readiness to learn is first. The nurse is caring for a client who's angry about being hospitalized. Which statement demonstrates therapeutic communication? I can see you're upset. Tell me what's bothering you. Okay, I like that. I can see you're upset. Tell me what's bothering you. Yeah, I mean, maybe sort of a command, but I could be right. Calm down or I'll have to call security. Okay, no, that's not what I would say. You shouldn't be angry. This is for your health. No, that's telling them they shouldn't be. I'm not going to tell them that. Never use the word should. Really, don't use the word should. It's sort of a bad word for therapeutic communication. Don't worry, it will all work it out. Okay, that's absolutely not. So A is the only one I even came close to liking. I can see you're upset. I definitely like that. Tell me what's bothering you. I may think to myself, well, I don't know if I'd be that direct. I might say, do you mind telling me what's bothering you? Or could you share with me what's bothering you? Or you seem upset about something. Would you like to share it with me? Like that may be better, but A is better than B, C, or D, definitely. So even if you don't love the tell me what's bothering you statement, like it's better than any of the others. So pick the best answer, right? It's the best answer out of all the ones that are there. The nurse is preparing a community health fair presentation for older adults. Which strategy best minimizes communication barriers? Okay, so usually they don't tell us the age unless it matters in the question, right? If the age is in the question, then it must matter. So it's older adults. Community health fair presentation, okay? Minimizing communication barriers. Well, providing lengthy written pamphlets with detailed text minimize communication barriers with older adults. I don't see how that would. I'm not saying it is bad, but I don't think it would minimize communication barriers. Speaking quickly to cover more material in less time, will that minimize communication barriers with older adults? No. Use large print visuals and allow extra time for discussion. Will that minimize communication barriers in older adults? Yes. Will assessing readiness to learn minimize communication barriers in older adults? No, that's just assessing readiness to learn is fine, but it's not going to minimize communication barriers. Okay, so communication barriers are things like they can't see as well, they can't hear as well, they're emotionally distressed, something like that, right? So C is really the only one that overcomes communication barriers. A client with cancer begins to cry during teaching about chemotherapy, which is the most therapeutic response. Now this is therapeutic. I want you to notice the last one says minimizes communication barriers. So that I have to focus on communication barriers. Here I need to focus on therapeutic response. So what is most therapeutic? Most therapeutic in general, okay, it doesn't tell us the patient has a comorbidity. Well, they do have cancer, but they don't have a diagnosis that would necessarily prevent them from learning, or that I have to communicate with them a specific way. So whenever I see the word therapeutic response, I usually think what is going to encourage them to talk about how they're feeling. So therapeutic communication is usually, in general, encouraging them to talk about their communication. Now, there's at least one question coming up where that's slightly different, but in this case, we're looking for what will encourage them to talk about how they're feeling. Don't cry, everything will be okay. That's not encouraging them to talk about how they feel. This must be very difficult for you. I'll stay with you. That's empathetic, and it may encourage them to talk, just therapeutic presence. We can continue the teaching when you're ready. That doesn't encourage them to talk. I'll get you some tissues and step out. That definitely doesn't encourage them to continue to talk. So it seems like C isn't C isn't necessarily wrong to say, but I wouldn't say it's necessarily empathetic. And B is quite empathetic, which is also therapeutic in this setting. So I would prefer, like if I were writing, I did write the question, but if I were like specifically saying what is most therapeutic out of all possible answers, then I would say this must be very difficult for you. Can you share with me how you're feeling, right? Encouraging them to talk to me. In this case, it doesn't necessarily say encourage them to talk to me, but it's still the most therapeutic out of all the options there because it's demonstrating therapeutic presence and empathy.
With YouTube Premium, you can watch ad-free, offline, and in the background, and listen ad-free on the YouTube Music app. That's right, one subscription, 2 apps. There's more to discover with Premium. Try 1 month free.
A nurse is developing an educational presentation for migrant farm workers who primarily speak Spanish. Which intervention best reduces communication barriers? Okay, an educational presentation for those who speak Spanish. Which intervention best reduces communication barriers? Provide Spanish language handouts. That's a good idea. Provide an interpreter. Okay, I have to do that. If I'm just going out myself, non-nurse, just talking to people who don't speak English, I guess I don't have to provide an interpreter, but I'm working as a nurse, and civil law actually says that we have to provide an interpreter for people who don't speak the language. So I do have to provide an interpreter. Focus on visual aids, maybe. Simplify medical terms. Well, that's not going to help if they don't speak English, although it may help if I did it in Spanish or had an interpreter. So C and D are okay, but only if I have an interpreter. So is it better to have Spanish language handouts or is it better to have an interpreter? Well, I have to have an interpreter, y'all. I may not even have any handouts. I may just, because it's a presentation, right? So I mean, certainly it seems like I would have handouts, but if it's a verbal presentation, I have to have an interpreter. So that's really best in this case. A nurse is planning a smoking cessation class for adolescents. Which teaching strategy is most effective? Okay, smoking cessation class for adolescents. So for adolescents, what do I know about teaching adolescents? Well, I know that adolescents starting at age 12, we can really teach them like an adult because they can understand cause and effect. And they can think abstractly. So starting at age 12, there's no really things I can't do as far as teaching them. Smoking cessation, okay, peer-led discussions and interactive media. So is that good for adolescents? Well, they're certainly all about peers, and certainly they like interactive media. So those seem appropriate for adolescents. Clearly present the risks of smoking using a lecture style. Is lecture style best for adolescents? Probably not. Probably not best. I mean, it's fine. If that was the only option, I could do it, but I don't think it's as good as peer-led discussions and interactive media. Ask students to come prepared to present statistics. Okay, that doesn't seem like the best thing. Ask parents to attend for improved reinforcement at home. No, we're not going to ask parents to attend because we want the kids to be able to speak freely. So this question seems to really be about, do you understand what's important to adolescents? So, and adolescents are teenagers generally. Usually adolescents are like 12, 13, 14, 15, 16, somewhere in there. And according to Piaget, adolescents starting at age 12, they can think abstractly. So there's really no limit on what we can do. So you can do peer-led discussions with adolescents. So that's not an issue. And we also know from development that peer group association is very, very important in ages 12 to 18. Like peer group association is very, very important. So peer group discussions or peer-led discussions would be really good actually in this. And then interactive media just keeps them interested. And they're very, they all know how to use media. A nurse is teaching a client with new onset heart failure. Okay, new onset heart failure. The client states, I'll never be able to understand all these medications. Okay, I can understand that. What is the best response? It's not as difficult as you think. That's sort of downplaying their concern. Let's review one medication at a time together. Okay, that's like saying, here's a plan. Okay, you feel overwhelmed, but here's a plan. Let's review one medication at a time together. That's fine. If you prefer, I can teach your daughter. Well, no, it doesn't say there's any reason why they can't learn it. They're just kind of overwhelmed. We can skip the teaching if it makes you anxious. No, we cannot skip the teaching. No, let's put a plan together. So the best thing to do is to review one medication at a time together, because that's sort of saying, okay, if it said, I hear you, or you seem overwhelmed, let's review this one medication at a time. I would like that answer better, right? If it said, you seem overwhelmed, let's review just review one medication at a time. Like that's a really good answer. So that answer is not there, but B is there, which is really close to what I would want to do. So if the answer you want is not there, you pick the answer closest to it. And so I would love to see some kind of a acknowledgement of how they're feeling, right? I'll never be able to understand all these meds. It would be better if we had some kind of acknowledgement of how they feel, like you seem overwhelmed, but it's not there, and it's not there in any of them. So then I have to pick B. Which client statement indicates a barrier to learning? I prefer written material to take home. Okay, that's not a barrier, that's just a preference. Please explain the side effects again. Okay, they want to hear it again, but it doesn't specifically say there's a barrier as a reason for that. I'd like my spouse to join the teaching session. That's not a barrier, that's just a preference. I can't concentrate when I'm in pain. All right, pain is the barrier, right? So really we need to control their pain before I can do any real teaching because they can't concentrate. A client states, I feel like my life isn't worth living anymore. What is the nurse's best response? I feel like my life isn't worth living anymore. What is the nurse's best response? Are you thinking of harming yourself? You have so much to live for. Tell me more about what makes you feel this way. Try not to think like that. All right, B and D are clearly not right. Okay, so clearly not right. So they feel like their life isn't worth living anymore. So could that mean they're thinking of killing themselves? It doesn't say they are thinking of killing themselves, but there's certainly an implication there that they could be. And so it is best, before we get into just therapeutic communication, we have to address their safety. So therapeutic communication is really important unless there's a safety need. And if there's a safety need, I really have to address that first. So I would say C eventually. I would say that eventually, but first I need to say, are you thinking of harming yourself? Now, it's also best because if I have to say anything, if I can only say one thing, I have to assess whether they're thinking of harming themselves. I have to do that. I attended online, I attended a Zoom conference with National Council of State Boards of Nursing last week where they talked about NCLEX changes to NCLEX. The good news is the 2026 change coming May 1st, 2026 is going to have very limited changes, very few changes. And I don't know if they're going to change the difficulty level. They didn't announce that, but they'll announce it by December of 2025. So they were talking about, for each question, one of the ways they assess each question is this a safety issue that the nurse needs to know to practice as a nurse? Or what kind of clinical reasoning does this require? And so in this case, it actually addresses both of those. This question addresses both of those. It addresses both a safety issue that the nurse has to know and clinical reasoning. Clinical reasoning says, I know what to prioritize here. Clinical reasoning is all about prioritization, which is why you get so many prioritization questions on your NCLEX. During a therapeutic session, a client with schizophrenia says, I hear voices telling me I'm worthless. What is the nurse's best response? I don't hear any voices. You must be imagining it. Okay, I don't like that answer. You're not worthless. You're a valuable person. Okay, that must be frightening, but those voices are not real. Okay, are you taking your medication? Okay, if I can only say one thing, do I want to say, are you taking your medication? I mean, I wouldn't mind knowing that, but I'm not sure that's the one thing I have to say. So there's a couple things here. So I'm going to go ahead and cross off B and D because those don't seem like therapeutic, because B seems like saying, oh no, you're not worthless. Like, it doesn't matter what the voices are saying. You're not worthless, honey. Well, we need to address the schizophrenic.
Your talent, your style, your book. Dorrance Publishing. Helping authors since 1920. We accept manuscripts in all genres. Full service publishing, book production, writing coach, manuscript development, promotion, and distribution. Rated A by the Better Business Bureau. Our books are printed in the USA. Manuscripts wanted. Get in touch with us for a free guide. All our consultants are located in the U.S. For over 100 years, we have been fulfilling dreams of becoming published. Become a published author with us. Dorrance, book publishing and promotion. Get your book published.
Psychosis. Okay, they're hearing voices. And it says during a therapeutic session. So during a therapeutic session, what that tells me is I'm not just meeting them. I'm working on the nursing care plan. So early on, for a psych patient who's got like schizophrenia, bipolar, depression, early on when I first meet them in the introductory phase, I'm going to be very empathetic, very empathetic. But once I'm into the working phase, we need to work on the care plan. So what kind of a care plan would you have for a schizophrenic client who's hearing voices? Well, you would be working on, because schizophrenics can learn they can learn reality, which means they can learn that the voices are not real. See, that's sort of a fallacy that every schizophrenic has to be medicated forever so they don't hear the voices. Actually, the medications that we give for schizophrenics often are not intended to be used long term. With schizophrenics and manics, and even severely depressed individuals sometimes have to learn is the voices or the delusional thoughts, the voices are not real. And so that's what we would be working on during the therapeutic phase, which is during a therapeutic session. So what I need to do is I need to acknowledge the feeling and present reality. That's should be part of the care plan during the therapeutic phase with a schizophrenic. So would it be better to say, I don't hear any voices, you must be imagining it? Because, I mean, that's fine, but I don't know that we say you're imagining it. That doesn't seem very therapeutic. Oh, I don't hear those, you're just imagining it. Or those must be frightening, that must be frightening. To hear voices, like that's acknowledging the feeling. That's a very therapeutic statement, but those voices are not real. Now that's saying, hey, look, I understand it's frightening to hear voices telling you that you're not valuable, that you're worthless, but those voices are not real. Now, would I want to assess whether they're taking their medications? Maybe. But maybe not, because maybe they're not on medications. I mean, maybe we're at the phase where they can understand reality and they haven't been taking their meds, and we're just trying to help them learn reality without taking the meds, because a lot of the meds have really significant side effects that they aren't crazy about. And I may at some point say, B, you're not worthless, you're a valuable person. Like I may at some point say that, but what is the nurse's best response? So what's the one thing I have to say? And you have to understand, we are clinicians at this point. We're not just their friends. Like if it was your friend, you might want to say, you're not worthless, you're a valuable person. Like that's totally fine for your friend. But you have to be clinically competent with a schizophrenic client. And that's what they're really asking you, if you are clinically competent during the therapeutic phase with a schizophrenic client. Okay, so that's it. That was kind of a lot, honestly. So it may not, I mean, maybe it wasn't for you. Maybe it was easy, but I hope that was helpful to you. One of the things that a lot of people tell me, at least a lot of my students have told me, is they struggle with just general psych questions, like therapeutic communication questions. They're never sure what the right answer is. So that's what I was trying to help you with. I hope that was helpful. So good luck on your NCLEX. Remember, don't give up. So just to sort of give you a summary, if you're interested, you can shut the video off now if you're not interested in this. But some of the things I learned when I went to that NCSBN conference, just going to give you a couple of things that I learned when I went to that. So the proposed changes to the 2026 RN test plan, which is going to be fully available in December of 25. The overall format and structure is the same. The categories and percentages and ranges have no change. There are minor edits for clarity, currency, and alignment. And there's going to be one new activity statement added to Category 1, Management of Care, one new activity statement added to Pharmacological and Parenteral Therapies, and one new activity statement added to Physiologic Adaptation, but they didn't report what those are. So as soon as I know, I'll make sure I take these out. And then proposed changes to the 2026 PN test plan. Overall format and structure is the same. Client needs, categories, and percentage ranges are unchanged. There's going to be minor edits for clarity and currency, and entry-level activity statement updates. One new statement added to Category 1, and two new statements added and one deleted in Category 7, which is reduction in risk potential. So again, they didn't tell us what those categories are, but I'll report it as soon as I know. And just so you know, there are comfort aids that are allowed without having to get a exemption, okay, like a testing exemption. So things like if there's a med you need to have, like if you have to have your EpiPen or your insulin or anything like that, you don't have to get a medical exemption. You just can bring those in. Bandages, braces, casts, cough drops, eye patches, eyeglasses, glucose tablets, hearing aids, inhalers, medical alert bracelets, medical devices. Those kind of things are all allowed without any exemptions. You don't have to get any exemption. And then mobility devices, walkers, wheelchairs, and so forth are all allowed without any exemptions. And then other approved items include earplugs and noise-reducing headphones. So you can take those without having to get any exemption. You can take a face mask or gloves without any exemption. You can bring a handheld non-electronic magnifying glass without any exemption. And you can bring tissues with you without any exemption. Okay, so those are things that are allowed. So if you've got a stuffy nose, you have to blow your nose, you can take tissues with you. And then there are 2 scheduled breaks during the exam. And what's going to happen is the proctor is going to ask you at these times, do you want to take a break? So there's going to, at 2 hours after the exam starts, 2 hours after it starts, the proctor is going to ask you if you want to take a break. You can say no. And then at 3.5 hours after the exam starts, the proctor is going to ask you if you want to take a break. Now, the timer does not stop during these breaks. So if you say yes, the timer does not stop. I'm just letting you know. And then there are unlimited breaks throughout the exam. You just have to raise your hand and the TA will escort you out of the testing room, okay? So you don't have to take any breaks. Even when the proctor comes and asks you, you don't have to take any breaks, but you can. Just remember the timer, the exam clock does not stop during those breaks. And then is there anything else I want to tell you about? Just some stuff about how they write the questions, which I don't think is going to matter to you. And then they did tell me, okay, they did tell us that they can have case studies that have 5 people, okay, 5 people case studies, where you'll be given 5 patients. And then the case study, every question determines, every question is about like prioritizing between them. Now, this should not intimidate you, okay? Do not be intimidated by this. All you have to do is use the same prioritization strategies that I've taught you on this channel. So just look at the prioritization videos and those prioritization strategies like expected versus unexpected and Maslow. Those are the 2 prioritization strategies that I've specifically put on here. There are other prioritization strategies, but those are the 2 I've put on here. If you want to know the others, you have to take our review. But those 2 are the ones I've put on here, and those are the 2 you need to prioritize between patients when you're asked about this, okay? So just make sure that you look at those and you're ready for those in case you get a case study where they give you 5 patients and then every question specifically revolves around a different patient. Okay, not a different patient, but you have to choose between patients. So it doesn't revolve around a different patient. It'll be like, which patient should you see first? Which patient's changing condition is most suggestive of hypoxemia requiring priority nursing assessment? So who should you assess first? These are just some that I wrote out myself as examples. Which patient's at greatest risk for rapid deterioration if not addressed first? So again, who are you going to see first? And then which action is the highest priority intervention to take immediately? So that you have to choose which intervention you take first. And then taking action after stabilizing patient B, which patient should the nurse see next? So y'all, the prioritization strategies I've taught you on this channel will help you determine for every single one of these types of questions. It'll help you with that. So I don't want you to be stressed about that. You know how to answer those questions, okay? I know somebody's going to ask me if I'll put a case study like that on the channel. So I'm going to have to ask Mark Klimick if I can. If he says I can, then I will, because we don't give away on the channel what we do, what we charge money for, right? So this is a supplement to what we do. Remember, we're an NCLEX business. And so we don't give away for free on the channel what we charge money for. And so I would need to ask him if I can do that, because currently I do not have a 5-person case study as part of the Next Gen tutoring. So I could possibly put that on here. I'll have to ask him if I can do that, okay? Love you guys. I'll see you later. Have a great rest of your day.
Why are these auto insurance ads lying to you? I'm a car insurance agent, and I've been in this industry long enough to call out the nonsense. These ads that promise you dirt cheap coverage, it's all smoke and mirrors. Today, I'm setting the record straight. The truth is, there are official programs that can lower your car insurance premium to just $38 a month, but only if you're 50 or older. Yep, if you're 50 or over, you could qualify for full coverage for as low as $38 a month. But that's the only catch. If you're under 50, this isn't for you. Anyone telling you differently is feeding you lies. There's no way to get those ridiculously cheap rates unless you're a senior. So, those ads claiming $38 car insurance for everyone, don't buy into it. They're just trying to trick you. But if you are 50 or older and want to take advantage of this $38 car insurance, scan the QR code on the right and see if you qualify. Time's ticking.
Don't ask just anyone a health question.
What do you do when you throw out your back?
Use caution when lifting heavy objects.
How do I eliminate back pain?
I'm not tracking any rain right now.
Back pain?
Got it. Calling back Shane.
Get it.
Ask a healthcare expert. Call HCA Florida's Consult a Nurse to speak with a licensed nurse 24/7 for answers and guidance. Call HCA Florida's Consult a Nurse. It's free.
Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews. Today we're going to be going back to the Blue Book. The Blue Book is right here. The Blue Book was published by Mark Klimek. You can get it on Amazon, and it's a bunch of facts that you need to know. So if you're wondering, what content do I have to know for the NCLEX? You need to know the Blue Book. And this is on page 46. It's under Health Promotion and Maintenance. So let's go ahead and get started. Hello, my friends. It's Dr. Sharon with Clinic Reviews, the home of the very best NCLEX review in the entire universe, in my opinion. You know, Clinic Reviews is the organization that runs this YouTube channel, and we do a phenomenal job preparing students to take NCLEX, but we also offer this YouTube channel for those of you who want a little extra practice doing questions or who don't have the money to pay for our Clinic Review, because really our goal is to see you pass NCLEX and to get some phenomenal nurses out there taking care of patients. So you can go to clinicreviews.com to sign up for our online on-demand 21 plus hour NCLEX review. You can also, let's see, what else can you sign up for? Small group tutoring. You can meet me live in person over Zoom if you want to sign up for our small group tutoring. And we also have a streaming service where you can find all of our YouTube videos plus additional videos through our streaming service. So, all right, so today we're going to do elimination, specifically bowel elimination, this sort of general information. And y'all, you really have to know stuff like this. This is fundamentals, and you have to know fundamentals in order to pass NCLEX. So if you have to choose between studying questions that are more complicated or questions that are less complicated, I would definitely study the less complicated questions, because those are the ones that you have to get right to pass NCLEX. So let's go ahead and get started. A nurse is caring for a client who has a stool specimen ordered to test for occult blood. Which instruction is most important to give the client prior to the test? So testing for occult blood. Avoid eating red meat for 3 days before the test. Collect urine and stool together for the sample. Fast for 12 hours before the test. Save all stools for 24 hours in one container. So I know that B is wrong. You definitely don't want to mix samples in one container. And you don't have to fast. This is not blood work you have to fast for, but not stool samples. And then D, save all stool samples for 24 hours in one container. No, we need one sample. That's all we need, not 24 hours worth. And so A, the question is, so if I rule out, because I rule out wrong answers to find the right answer. So if I rule out B, C, and D, the question is A possibly right? And I have heard that red meat can give you a false positive for occult blood. And since I have heard that before, it's not something that I'm like super expert on, but I have heard that before. And so I'm gonna go ahead and pick A. All right, the nurse is interpreting a client's stool colors. Which findings indicate an abnormal stool? Black tarry stool, clay-colored stool, green stool in a 2-day-old infant, bright red blood coating the stool, or brown stool. Okay, so black tarry stool indicates bleeding, and it's digested blood. So black tarry stool is digested blood, which means it's an upper GI bleed, most likely. And the vocabulary word for that is melena, M-E-L-E-N-A, melena. Clay-colored stool. Clay-colored stool is when there's an absence of bile in the stool and it turns clay-colored. So that's abnormal. Green stool in a 2-day-old infant is actually normal. That's a normal color for a 2-day-old infant. Bright red blood coating the stool, that is fresh blood in the stool. That is called hematochezia. So A is melena, E is hematochezia. And then that's abnormal, obviously. And then brown stool is the color. It's actually the bile in the stool that turns it brown. So the only abnormal ones here are A, B, and D.
Are you preparing to take the NCLEX test? Check out UWorld's award-winning test prep. You could spend hours shopping for all kinds of different resources, or get UWorld and have everything you need to ace NCLEX all in one place. You could study by yourself, or have expert educators educators on your side. You could be confused and stressed, or feel in control as you work through difficult concepts. You could hope for a passing score, or track your progress and pass with UWorld. If you're looking to take the NCLEX, visit nursing.uworld.com to get the best prep resources all at one affordable price.
A client reports black, sticky, foul-smelling stools, which is the nurse's priority interpretation. Client ate a large amount of spinach, possible upper GI bleed, fatty malabsorption, iron supplement side effect. So, black, sticky, foul-smelling stool. So that's usually old blood, so it doesn't have anything to do with spinach. Possible upper GI bleed. So that's when it's gone through the whole GI tract, and now it is digested blood. So that B is a good answer. Fatty malabsorption, no, that's not what it looks like. Fatty malabsorption, when you have too much fat in the stool, that actually changes the stool in a different way. Iron supplement side effect, no, that is not an iron supplement side effect. So it's possible upper GI bleed. The nurse is caring for a client with steatorrhea. That is the word for fat malabsorption. So instead of the fat absorbing into the body, it's excreted in the stool. So you have very fatty stools. Which characteristics should the nurse expect? Bulky, pale in color, extremely foul odor, greasy, or pencil thin. So it is going to turn it bulky, so it's going to be larger than normal. It is going to be pale in color, so fat turns it pale in color, steatorrhea. It does have an extremely foul odor, and it is greasy. So if you just think of fat as, and I mean like if cooking fat, right? Cooking fat is greasy. And it's also pale in color usually, right? Cooking fat's usually pale in color. So that sort of maybe seems just common sense, B and D. And then pencil thin usually means there's an obstruction of some kind. So that is not steatorrhea. So A, B, C, and D are the correct answers. A client's stool specimen comes back positive for occult blood. Which action is most important? Reassure the client it is likely diet related. Encourage more fluids and fiber. Notify the healthcare provider for further evaluation. Repeat the test immediately. All right, so is it wrong to notify the healthcare provider? It is not wrong to notify the healthcare provider. However, if there's something you can do before notifying the healthcare provider, then you should do that. Okay, if there's something you can do before notifying the healthcare provider, you can do that. So if it's positive for occult blood, we are concerned that there's bleeding in the stool, or blood in the stool, or bleeding in the GI tract. So is it appropriate for us to assume it's something else? Like, can we assume it's something other than bleeding? Could it be something other than bleeding? Sure, it could be red meat in the diet, right? A false positive. So is it appropriate for me as the nurse? Because I'm not the diagnostician, so is it appropriate for me to assume that? And the answer is no, that's outside my scope of practice. So it's actually outside my scope of practice to interpret the test as being diet related. So A is outside my scope of practice, so I can't do that. Encourage more fluids and fiber. Well, I could encourage more fluids and fiber once the doctor determines that there's a reason for the bleeding that's related to fluids and fiber. Okay, so once the doctor says, well, they're constipated and it's causing some irritation in the lining of the GI tract, or they have GERD, and they're having some bleeding in the stomach, right? I mean, something that's maybe related to something other than serious bleeding, then maybe I can encourage more fluids and fiber. But it's inappropriate to do that right now because I don't know what's going on. If it's bleeding, the doctor needs to determine that. So C is an appropriate option. Notify the healthcare provider for further evaluation because I don't know why it's positive. D, repeat the test immediately. So don't ever choose to repeat the test on the NCLEX because the NCLEX is a perfect world. So what it means that NCLEX is a perfect world is it means that the data that you're given is accurate. Whether the patient reports it, it's accurate, or whether it's a data result, a test result, it's accurate. So that's why you don't repeat tests on the NCLEX. In real life, if you want to repeat the test, that's totally up to you. Okay, that's totally up to you. But on the NCLEX, you don't repeat tests. So I can cross off A, B, and D because they're not appropriate right now. Certainly they're not most important right now. And the provider is going to have to decide why it's positive for occult blood. So C is the correct answer. The nurse reviews the chart of a client with hematochezia. Hematochezia is another vocabulary word you have to know. It means fresh blood in the stool or coating the stool. So it's lower GI bleeding, maybe rectal bleeding. Which finding would the nurse expect to see documented? Black sticky stool, bright red blood mixed with the stool, that's hematochezia. Pale bulky stool, that's steatorrhea. Yellow frothy stool, I don't have a name for that. So B, I know, is hematochezia. So that's the correct answer. A nurse is caring for a client taking iron supplements. Which stool description indicates an expected finding rather than pathology? So we've all heard that stool, maybe you haven't, but most nurses have heard that iron turns the stool black. So is that true? Because isn't that the same as black tarry stool? And the answer is no, it's not pure black. Black and tarry, so that's not the right answer. And loose, pale, bulky stool, steatorrhea. It's a dark greenish black stool. That's what iron does. It turns it a dark greenish black, and it's not tarry and it's not foul smelling. And obviously it's not bright red residue on the toilet tissue. So that C is the correct answer. The provider orders a stool culture. The nurse explains that this test is used to identify which conditions: parasitic infection, bacterial infection, malabsorption of fat, viral infection, blood in the stool. So the word culture means they're going to put it in a petri dish and they're going to see what grows. And the only things that grows are infections, right? So viruses, bacteria, parasites, ovum, those kind of things will grow in a petri dish. But fat doesn't grow in a petri dish and blood doesn't grow in a petri dish. So even if you don't know what specifically a stool culture tests for, you should pick the ones that are infections, because that's what a culture is. It's growing something in a petri dish and then testing to see what it is after it grows a little bit. So the correct answers are A, B, and D, because these are the infections. A client who has not had a bowel movement in 4 days reports abdominal distension and pain rated at 7 out of 10. Which intervention should the nurse perform first? All right, so it sounds like constipation. I'm unhappy about the pain. That bothers me. And 4 days is a long time to go without a bowel movement. So administer the prescribed stool softener, notify the healthcare provider, assess bowel sounds and abdominal shape, or encourage increased oral fluids. So a lot of nursing students know the prioritization strategy of ADPI, always assess first. Okay, so here's the rule. It's not so much that you always assess first, but you assess if you don't have enough information to take action. Okay, I don't have enough information to take action. They haven't had a bowel movement in 4 days, and pain is rated at 7 out of 10. This is concerning to me. I'm not ready to call the healthcare provider yet because I need to have more information. So I really want to assess, do they have bowel sounds? Are they distended? Like C is a great answer in this case because I don't have enough information to take action. It's too soon to administer the prescribed stool softener. These are pretty significant findings, especially if they have absent bowel sounds and a distended abdomen. I'm not going to do a stool softener for that. Like, I'm going to call the healthcare provider for that. But if they have good bowel sounds and their abdomen is soft and non-distended, then I may go ahead and encourage oral fluids and give the stool softener. But I have to do an assessment first. Again, assessment is the first thing you do when you don't have enough information to take action. A post-op client who is receiving opioid analgesics reports no bowel movement for 3 days, which is not that unusual when someone's on opioid analgesics. Which nursing action should the nurse take first? Administer a prescribed laxative, encourage ambulation, offer warm fluids, teach about stool softeners for home use. So here we don't have an option to do assessment. Okay, so I'm going to have to do something because there's no assessment option. So which are appropriate interventions? Well, prescribed laxative is an appropriate intervention. Ambulation is an appropriate intervention. Maybe teaching about stool softeners at home, but that's a maybe. I know A and B are appropriate. So I'm going to cross off D. I mean, fluids is okay. To give fluids, do they have to be warm? I don't think they have to be warm. So C might be okay, but it's not like my first option, I don't think. So I'm going to cross off C and D. So the question is, would I give a prescribed fluid laxative and then encourage ambulation, or would I encourage ambulation and then give a prescribed laxative? So another prioritization strategy that I've heard students tell me is that you do the least invasive thing first. So the least invasive thing first does work only when there's 2 appropriate interventions. Okay, you've already decided these are both appropriate interventions, and these are both appropriate interventions because it's not surprising they haven't had a bowel movement post-operatively. So the anesthesia slowed down their guts and it probably paralyzed the bowel for a few hours. And then the opioids decreased peristalsis. So this is an expected finding. So when I have an expected finding, I need to treat that. So I have two appropriate interventions. So I have two appropriate interventions. So I am going to do the least invasive first. But remember, only choose the least invasive first when both interventions are equally appropriate. Okay, so that is it. That was short and sweet. I hope that was helpful to you. Thank you for being a part of our Clinic Review family. Don't forget to study your fundamentals, y'all. Okay, don't forget to study your fundamentals. We love you. We are hoping that you pass NCLEX. Let me know in comments sometime if you did. All right, take care, and we'll see you later.
Then what about the moment when you actually realize that you're not here by accident? That there is a God that really loves you so much that sent his son on a rescue mission for you.
This is something special.
We're going to do that.
On the other side of temporary pain, you meet your other self.
God is setting you up to be blown away.
Okay, guys, we have one more.
It's huge.
Give the gift of adventure at Bass Pro Shops and Cabela's. Treasure the magic of the season at Santa's Wonderland with a free photo with Santa. Bass Pro Shops and Cabela's. Your adventure starts here.
Hello, Clinic Review family. It's Dr. Sharon. Today we're talking about hyperemesis gravidarum. You can find it in the Blue Book. The section on hyperemesis gravidarum in the Blue Book is pretty short. I'm expanding on it just a little bit, so let's go ahead and get started. Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews, the home of the very best NCLEX review in the entire universe. Mark Clinic does that NCLEX online on-demand NCLEX review. It is good for RNs and PNs. I get that question quite a bit. If you do it as a PN, you're going to be a little over-prepared. You're going to find the PN exam, pretty, you're going to be successful on it. But you can also use it for either one you want to. And we also have a streaming service where you get the videos I put on YouTube. You get all those videos for without any commercials. And there's probably at least 10 extra videos on the streaming service. We don't cover the NCLEX review content in these videos or in the streaming service. It's totally different content. Primarily, the streaming service is for you to learn some information and to practice questions. And then we have our small group tutoring. You can buy it as a monthly package. All right, let's go ahead and get started. Hyperemesis gravidarum is specific to pregnancy. It's severe prolonged vomiting. So let's go ahead and look at some questions so you can learn about it as we go. A 28-year-old client at 12 weeks gestation presents with excessive nausea and vomiting. She's lost 5% of her pre-pregnancy weight and has ketonuria, which is ketones in her urine. Which of the following is the most likely diagnosis? Normal pregnancy, early pregnancy nausea, hyperemesis gravidarum, gastroenteritis, cholestasis of pregnancy. All right, well, obviously you know what the right answer is since we're doing hyperemesis gravidarum here, but let's talk a little bit about the difference between normal pregnancy nausea and hyperemesis gravidarum. So hyperemesis gravidarum is severe and prolonged into the second trimester, whereas early normal pregnancy nausea is not nearly so severe, and it does not go into the second trimester. A client at 14 weeks gestation has been experiencing severe vomiting and is diagnosed with hyperemesis gravidarum. The nurse understands that which of the following is a key differentiation between hyperemesis gravidarum and normal morning sickness. Oh, well, I already told you the answer to this. Hyperemesis gravidarum usually resolves by the second trimester. Wrong. that is normal morning sickness. A is normal morning sickness. Hyperemesis gravidarum does not require medical intervention. That's false, actually. One of the key factors of hyperemesis gravidarum is it's such severe vomiting with dehydration, and sometimes can even lead to starvation and acid-base imbalances that it does require medical intervention. Hyperemesis gravidarum is psychosomatic in nature. It is not, although there can be a psychosomatic component to it, but it is not psychosomatic in nature. Hyperemesis gravidarum is severe and prolonged. That's the correct answer. For women who are very upset about being pregnant, or they are in denial about their pregnancy, or I don't know, they have a lot of emotional feelings associated with it. It often does make their nausea and vomiting worse, but it doesn't always lead to hyperemesis gravidarum. So when I say there could be a psychosomatic component to it, that's what I mean by that. A client with severe hyperemesis gravidarum has been unable to eat adequately and is showing signs of starvation. Which laboratory results should the nurse monitor closely for to assess for starvation-induced complications? Blood urea nitrogen, serum albumin, serum glucose, or serum ketones? Well, I'm going to rule out blood urea nitrogen. That's a waste product, so I don't know that BUN goes up with starvation. Serum albumin, that does go down with malnutrition, so we can leave that on the list. Serum glucose does go down with starvation, so we'll leave that on the list. Serum ketones. Now, serum ketones go up when fat is being metabolized for energy in the absence of glucose. So when glucose is metabolized for energy, it releases a substance called acetyl-CoA. And acetyl-CoA enters the fat metabolism cycle and allows fat to be metabolized with low waste. The waste product of fat metabolism is ketones. So if you have glucose metabolism or carbohydrate metabolism in alongside fat metabolism, then you don't release a lot of ketones. But if you have fat metabolism without carbohydrate metabolism, you release a lot of ketones. And one of the things about starvation is they do tend to become ketotic. So you can have a low serum albumin and a low serum glucose and not be starving. You may be malnourished, but not necessarily starving. Where serum ketone goes up, that is an indication of starvation. So we're going to pick that one. A nurse is providing dietary counseling to a pregnant client who struggles with mild hyperemesis gravidarum. Okay, I don't know what mild hyperemesis, maybe is the kind that doesn't need intervention, but okay, whatever. Which recommendation might help reduce her nausea and vomiting? Include ginger in her diet. I don't know. Avoid all carbohydrates. Well, I know that's not true, because if she avoids all carbohydrates, she's going to starve. So that's out. Only eat 3 large meals a day. I know that's not true, because large meals is more likely to induce nausea and vomiting, whereas frequent small meals would be better. Drink fluids with meals to speed up gastric emptying. Drink fluids with meals to speed up gastric emptying. I don't know. I don't know how that would help with nausea. It seems like if you drink a lot of fluids, you're going to fill up with fluids and you're not going to get the calories that you need. So I don't know if ginger in the diet is helpful. It seems to me like ginger has been used to treat nausea, because isn't ginger ale given to people? Like I've given ginger ale to my patients before who are nauseated to help them. So for me, it makes sense that ginger could possibly help. Now, doesn't mean it's always going to help. I don't know. I don't know what the statistics are on helping, but it makes sense. And I know B, C are bad. B and C are out. And I know D is not a good option, because if we tell her to just drink lots of fluids, she's not going to get as much food. She's going to fill up on fluids. And I don't know that it's going to help with nausea. So I'm going to go ahead and pick ginger in her diet. So when you get a question that you're not quite sure about, don't immediately cross off an answer. Do you go, I've never heard of that? No. Okay, if you've never heard of it, so go, well, maybe, let's see what the other answers are. One of the mistakes, and Mark talks about this in the interview I have with him posted on our YouTube channels. He talks about people who preemptively cross off answers. So don't preemptively cross off answers. Keep them like as a question mark, or maybe that's an option, and until you see what the other answers are. A pregnant client with hyperemesis gravidarum asked the nurse why she can't take oral liquids yet and has to receive IV fluids. What is the best response by the nurse? So early on, when they're first admitted with hyperemesis gravidarum, we rehydrate with IV fluids. We usually keep them NPO for a short period of time to kind of rest the gut. So let's see what the answers are. Your vomiting has been severe, and it's important to rest your stomach before giving you anything by mouth. All right, that's probably not how I would say it, but that is true. B, this is the healthcare provider's standard orders for anyone with hyperemesis gravidarum. So that's just not a good answer. That's not client focused. It's not therapeutic. So just because something may be true doesn't mean it's therapeutic, and it's not helpful. So I don't like B. As soon as your laboratory values are normal, you'll be allowed to drink clear liquids. I don't think that's what makes that decision. Your baby's health depends on you receiving fluid IV first. Is that true? Let's see. I'm going to cross off B and C. So let's compare A and D. Let me see. What is the best response about why she can't take oral fluids? Your vomiting has been severe, and it's important to rest your gut or stomach before giving you anything by mouth, or your baby's health depends on you receiving fluids IV. So I like A better because that explains why, as opposed to just saying, oh, D is almost like a don't worry about it. It's for your baby's health. It's not explaining why that is. So A, I like as a better answer. The nurse is educating a client with hyperemesis gravidarum about dietary changes to help manage her condition after discharge. Which recommendation is appropriate? So HG after discharge. Consume high-fat foods to slow gastric emptying. That doesn't seem like a good idea. Eat a large meal every few hours to maintain blood sugar levels. Large meals are not a good option with nausea, just in general. I'm not just talking about with hyperemesis gravidarum. Drink small sips of fluid with dry foods like crackers. That seems like a good idea. That keeps kind of a consistent fluid and foods and fluids without putting too much in. Avoid eating protein sources. I don't know why you have to have protein for the baby to grow. You have to. So that doesn't seem like a good idea. So out of these options, C is my best option. And it's pretty consistent with like what I know to be true, where we keep them NPO, or if it's not as severe and we can send them home, or we're getting ready to send them home, we're going to teach them about smaller amounts, sips with crackers, like a dry carbohydrate kind of a thing. So that's a good option. A nurse is evaluating the lab results of a client with hyperemesis gravidarum, which finding is consistent with the diagnosis. Elevated liver enzymes, low urine specific gravity, elevated hemoglobin and hematocrit, or metabolic acidosis. Okay, so liver enzymes, I don't know why those would be elevated. It's not something I'm familiar with, so I'm going to cross it off for now. Low urine specific gravity. So low means the urine is more dilute. It means it has more water in it. And if they're dehydrated, they're not going to have a low urine specific gravity. They'd have a high urine specific gravity. So B is out. Elevated hemoglobin and hematocrit. So one of the reasons H&H can be elevated is serum concentration or hemo concentration. So when you lose a lot of fluids in a quick period of time, not blood, you're losing blood. Okay, they're not bleeding out. They're bleeding out, their H&H is going to go down, but they're losing vascular volume. Their H&H can actually go up because of concentration. So I like C, metabolic acidosis. Metabolic acidosis is not the answer. It is a metabolic problem, but it's not metabolic acidosis. And we've got another question coming up, so I'll talk about why that is in another question. So that's hemo concentration is the reason for C. The nurse is caring for a pregnant client with hyperemesis gravidarum who's dehydrated. Which IV solution would the nurse expect to be prescribed to correct dehydration? 0.9, D5 water, half normal saline, or LR. So I don't think you'll get a question exactly like this, because honestly, you could do A or D. A or D would be fine, and it's really up to the prescriber. But I will tell you that on the NCLEX, normal saline is almost always the right answer. And the reason it's the right answer is because 0.9 normal saline is isotonic. Now, LR is also isotonic. However, on the NCLEX, they prefer normal saline. It's isotonic, which means it can expand vascular volume without moving fluid around a lot, right? If it's hypotonic, then fluid is going to leave the vessels and can enlarge the cells. And if it's hypertonic, it's going to pull fluid in and and dehydrate the cells. So isotonic solution allows you to increase vascular volume without moving fluid around a lot. And the key thing, you got to understand, the key thing here is dehydration. They didn't say they were hypoglycemic. Okay, if they're hypoglycemic, I'd probably do D545 because I'd want to add some water or some dextrose to that. So that's probably what I would do. But this person is just simply dehydrated, and the best option for expanding vascular volume is 0.9. The nurse is caring for a client with hyperemesis gravidarum, which acid-base imbalance with a nurse watch for. Okay, here's the one I was telling you about. So when they give you a scenario and then they say, which acid-base imbalance is it? Here's how you answer that question. First of all, you say, is it a respiratory problem? If it's a respiratory problem, then cross off the metabolic options, okay? This is not a respiratory problem. This is a vomiting problem. So we're not going to pick A or B. So those are out. Now, the question is it acidosis or alkalosis? Well, as far as GI is concerned, GI, I always say, because this is what helps me, upper GI, think up. Upper GI is stomach and up. So emesis is stomach and up, right? So emesis or upper GI is up. So think up pH. Up pH is alkalosis. Lower GI, like diarrhea, lower GI is a downward, lower, down. So think low pH or acidosis. So hyperemesis gravidarum is upper GI, it's vomiting. So we have to have our pH go up. And it's not lung, it's not respiratory, so it has to be metabolic. So the answer is metabolic alkalosis. Now, I'm not explaining to you all the whys and hows and the pathophysiology of that. And that's because this is an NCLEX prep channel. I'm helping you prepare for NCLEX, and I'm helping you learn how to answer the questions so you can get them right. If you work in a place where you have hyperemesis gravidarum patients, you probably want to figure out why they're experiencing metabolic acidosis. And maybe at some point, I think I talk about it more in some of my acid-based lectures, but I'm just not going to talk about it here because it doesn't really need to be talked about here. A pregnant client at 10 weeks gestation is being treated for hyperemesis gravidarum. She asked the nurse why she needs to receive vitamin B6. What is the nurse's best response? Vitamin B6 helps to reduce nausea and vomiting. Vitamin B6 improves the function of your liver. Vitamin B6 prevents neural tube defects in the fetus. Vitamin B6 helps regulate your blood pressure. So I know C is out because folic acid is what prevents neural tube defects. So I'm crossing that off. Now the question is there a liver or blood pressure problem with hyperemesis gravidarum? Well, there could be a blood pressure problem, but I've never heard of vitamin B6 regulating blood pressure. And listen to me, if I'm going to use my common sense, and you cannot throw your common sense out the window, if I'm going to use my common sense, I say to myself, this is a vomiting problem. Why else would I give vitamin B6 other than to reduce nausea and vomiting? So this is a common sense question. Even if you didn't know vitamin B6 can help, which honestly, I didn't know vitamin B6 could help, but I could still get it right because I use my common sense and I say, why would I pick anything else other than reducing the problem that they're admitted for? A pregnant client with hyperemesis gravidarum has lost 8% of her pre-pregnancy weight and now presents with fatigue and weakness. Which electrolyte imbalance is the most likely cause of these symptoms? Well, fatigue and weakness are associated with any kind of electrolyte imbalance, but she's vomiting. So we're going to think that she's vomiting up a lot of those electrolytes in her gastric acid. So there's a lot of electrolytes in the GI tract. So if she's vomiting those up, she could be vomiting up potassium. She could be vomiting up sodium as well, honestly. I suppose she could be vomiting phosphate and calcium. However, I think it's more likely she's got a hypo problem because if she's vomiting stuff up. And it's more likely, just because I know how NCLEX tests, they're not testing me on hypophosphatemia here. They want to know, watch for electrolyte imbalances. And which electrolyte imbalance are you more likely to see here? And it's more likely to be hypokalemia. So that's the correct answer. Oh, I changed it to hypo. Don't worry about it. I would still, no matter whether the natremia was hyper or hypo, I would have still picked hypokalemia because that's the most common problem and more likely to cause fatigue and weakness. In hyperemesis gravidarum, which factor is most commonly cited as a contributing cause of the severe nausea and vomiting experienced by the client? elevated HCG, high levels of estrogen and progesterone, decreased thyroid hormone levels, stress and psychological factors. Well, I don't think it's likely to be C or D. So it's either going to be elevated HCG or elevated estrogen and progesterone. And, there's a lot of other reasons people can have high levels of estrogen and progesterone and they don't have hyperemesis gravidarum. It's only with pregnancy really that you see elevated HCG levels. So that's a pretty good guess. Now, let me tell you why that actually is the correct answer. So HCG levels are elevated in multiple pregnancies. So multiparity, multiple pregnancies, multiparity is a risk factor for hyperemesis gravidarum. The other thing that's a risk factor is a molar pregnancy. A molar pregnancy is when for some reason the cells of the placental cells grow more than they should, and sometimes they can cause little, I don't want to say tumors, but they're benign, but they're like little tumors. When you have that increased level of placental reproduction, you have increased HCG levels. That's what a molar pregnancy is. And just so you know, molar pregnancies, sometimes there's a fetus and sometimes there's not a fetus with a molar pregnancy. And even if there is a fetus, it is never, they're not able to come to term. So molar pregnancies are associated with no actual pregnancy. And then multiple pregnancies is also a risk for hyperemesis gravidarum. All right, that's it. I hope that was helpful to you. And I hope you have a great rest of your day. Thanks for being a part of the Clinic Review family. Good luck on your NCLEX or your standardized tests, whatever you're taking. Watch some of our other videos. And thank you for watching to the very end. Love you guys. Bye. Hello, Clinic Review family. Today I'm finishing up what I started a couple days ago, talking about dangers and discomforts of pregnancy. Today we're doing the 3rd trimester. So let's go ahead and get started. Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews, the home of the very best NCLEX review in the entire universe, in my opinion. Mark Klimek does those online on demand, y'all. He is a phenomenal teacher. He's literally taught me everything I know about NCLEX, about teaching, about writing questions. He has an amazing gift, and he does his NCLEX review is different than any other NCLEX review you can find anywhere. There's a reason why so many people love it so much. And I'm just telling you, if you have heard about Klimek reviews, it's because somebody else told you about them or somebody else recommended them, because Mark Klimek does not advertise. Have you ever seen any advertising for Klimek reviews? You might say, well, Sharon, you do advertising on YouTube by having this channel. You're right. We do advertising, but it's also on YouTube, as this channel is sort of like advertising for us, but we also offer a service through this channel. So Mark Klimek literally has never done any advertising. He has always said, I'm not going to advertise. If what we're doing works, people are going to tell other people about it. And that's how I'm going to know that what I'm teaching them is helpful. So he's a great guy. He's a very unique guy, pretty amazing. His attitude toward things is pretty phenomenal. So we also offer a small group monthly tutoring packages as well as a streaming service. So let's go ahead and get started with our 3rd trimester. This is in the Blue Book. You can get the Blue Book on Amazon, or you can go to clinicreviews.com. And if you look up at the top, it'll say, it'll have different tabs. You click the Blue Book tab and you can get the app. Okay. So if you're outside the US and you can't order the Blue Book, or outside North America and you can't get the Blue Book from Amazon, you can get it. You can get the app. Actually, probably you can get Amazon in Europe. I have no idea. I've never tried to order Amazon in Europe. So if you can get the Blue Book in Europe, let me know, because I didn't know you could do that. All right, let's go. A client at 34 weeks gestation comes to the prenatal clinic reporting several symptoms. Which findings should the nurse report to the healthcare provider? So remember, we report unexpected findings to the healthcare provider. That's one of the prioritization strategies that I've taught you. You know, when they give you very little information about the client, all they do is tell you their diagnosis, or they tell you their 34 weeks gestation, which is third trimester. And then it says, what should you report to the healthcare provider? Or what should you be most concerned about? Or what requires your immediate intervention? You say the unexpected findings. So that means we're looking for things that are expected at 34 weeks, and we're not going to report those to the healthcare provider, because I, as the nurse, am expected to manage the expected signs and symptoms, the expected discomforts, the expected side effects, whatever it is. I'm expected to treat those or manage those, and I teach the patient how to manage those. Okay, so that's why you get so many teaching questions on the NCLEX, because the NCLEX expects you to identify expected side effects, expected findings, and to help the patient manage those. We're looking for the unexpected finding in the third trimester. The third trimester is from about week 25, 26 to week 36.
Smile Zemi. The Smile Zemi tablet offers a home learning method that encourages independent learning and fosters confidence, leading them to a future full of smiles. This unique learning cycle encourages independent study. The Today's Tasks feature suggests lessons best suited for your child to help them take initiative. By turning your child's hard work into exciting rewards, Smile Zemi encourages your child to keep learning and to stay motivated. And tracking your child's learning activities is made easy, so you can see their progression and praise their success. Smile Zemi's math and English language arts materials are aligned with the Common Core state standards. Your child can build foundational and applied skills with Smile Zemi's progressively scaling learning system, where no two exercises are ever the same, fostering their critical thinking and problem-solving skills. Not only are the materials special, so is the tablet. It's designed exclusively for at-home learning with no access to distractions or dangers through video platforms, web browsers, or gaming apps. This state-of-the-art tablet employs unique technology allowing accurate writing even while resting a hand on the screen, making writing and erasing into a tactile, stress-free experience. Smile Zemi's lessons have proven results in increasing math and reading scores. At 2 select elementary schools in the U.S., children used Smile Zemi for 8 weeks, and their grade went up by 29 percentage points in math and 21 percentage points in English language arts. Here are some rave reviews from the education community.
We were looking to get better at something, and in the short time that we completed that program, our students are better at math than they were before we started.
By giving this rote practice on a daily basis, our students were able to see tremendous gains in the area of spelling and in grammar. Particularly, we went up 15% in the area of spelling and 35% in the area of grammar.
I think Smile Zemi will be a great option to help students in the United States. It increases their abilities. We've seen through our pilot program that the students' abilities do increase in mathematics and language arts skills significantly. I think that anything 20% is an amazing percentage of increase in students' abilities in a short period of time.
Smile Zemi provides all that you would expect from a learning center and more. With no need for an extra commute added to their day, your child can master fundamental skills while having fun, and you can feel confident in closely observing their progress. A Smile Zemi subscription starts at $79.99 per month. The dedicated tablet is a one-time purchase of $329.99. This comes to about 1/5 the average cost of a learning center. With a small payment now, you can invest in your child's future. You can start with a worry-free home trial. With Smile Zemi, let's boost your child's learning. Learn, grow, smile. Smile Zemi.
When your kid is hurting and there's nothing you can do about it, that's the worst feeling in the world.
I don't think anybody ever expects to hear that their child has cancer. It's always one of those things that happens to somebody else, but it's definitely feels like your soul is sucked out of your body when they tell you that it's your baby. And you would do anything to get them to the best place that they can be for their treatment. And I knew with everything in my soul that that was St. Jude and that we had to get here. Everything about cancer is already so hard. I can't imagine how people do this without St. Jude.
My name is Hunter. I'm at St. Jude because I had osteosarcoma. Osteosarcoma is a special cancer that's in the bone, so they had to amputate my leg.
Good catch. My hero.
Here at St. Jude, you don't ever have to worry about how much treatment costs. You never get a bill, ever, for any of it.
1 in 5 children diagnosed with cancer in the U.S. will not survive. St. Jude gives kids with cancer the chance they deserve. Help.
And then 37 is full term. Now that's still the third trimester, right? But week 37 is full term. So from 37, 38, 39, week 40 is the average week that women deliver in the United States. And if you haven't, if the woman hasn't gone into labor by week 40, this isn't a testing question. I'm just telling you the reality. If you haven't gone into labor by the time you're in week 40, usually they'll schedule an induction for you. I have my own personal opinions about the medicalization of delivery, but I'm not going to get into that on the clinic YouTube channel. That probably would not go over well. All right. A client at 34 weeks gestation comes to prenatal clinic reporting several symptoms, which findings should they report to the healthcare provider? Increased urinary frequency during the night. That is expected discomfort during pregnancy. First trimester and third trimester is when they experience urinary frequency. Persistent headache and blurred vision. Headaches are pretty common because of the hormonal fluctuation, but blurred vision is not expected, and a persistent headache is really not expected. Occasional headaches is okay, but a persistent headache bothers me. Occasional irregular contractions, that's okay. It's actually the body getting ready for delivery, and so it stimulates the uterus to contract every once in a while. Those are called Braxton Hicks contractions. They haven't gone into labor. Irregular contractions does not mean labor. Regular contractions is labor. Mild ankle swelling by the end of the day. That's expected. Sudden swelling is unexpected. Mild ankle swelling at the end of the day is expected. Now, persistent headache and blurred vision is an indication of possible preeclampsia. So we need to get them into the office and assess them while they're already at the clinic. We need to assess their blood pressure. We need to do a urinalysis. We need to see if they've got protein in their urine and all what's going on with that. I have sort of harped on preeclampsia in these last 3 videos because y'all, good chance you're going to get a preeclampsia or a postpartum hemorrhage question on the NCLEX, because those are 2 of the biggest complications associated with pregnancy and delivery. And so they want to know if you know how to manage those. Okay, so make sure that you know the signs and symptoms of preeclampsia. During a prenatal visit at 36 weeks gestation, a client mentioned she's having difficulty sleeping at night. Which additional symptoms should be reported to the healthcare provider? So insomnia is an expected discomfort in the 3rd trimester.
Stronghold of my life, whom shall I fear? Though the arrows may fly, by night and by day, I will not be afraid.
Are you ready for a great adventure?
Celebrate Christmas at the movies. Buy tickets now at angel.com/savings. Exclusively in theaters December 19th.
Never sue the other driver after a car accident. There's a better way to get paid a way bigger check without having to go to court or pay expensive upfront legal fees. Listen, if you've been in a car accident in the past year, even as a passenger, you could be owed a significant cash payout. While most victims are struggling with insurance companies and lawyers, others are receiving 6- and 7-figure payouts without ever stepping foot in a courtroom. Here's how to never have to worry about money after a car accident. It's called the 2025 Compensation Program, and we recently launched it across a couple more states to help victims get the maximum amount they're owed without the usual hassles of dealing with insurance directly, going to court, or paying expensive upfront legal fees. And right now, we're looking for 10 more car accident victims who want to try this program for free and get paid maximum accident compensation. No more money problems, no more stress. Take Josh's story. When Josh first came to us, he didn't think his case was worth anything. He was dealing with stress, medical bills, and didn't want to bother with the process. Insurance offered him $4,000, but after using the 2025 compensation program, he walked away with over $100,000 without ever stepping foot in the courtroom. And this was over 5 months after his accident. Here's how it works. Within a few clicks, you can find out what your accident could actually qualify for just by clicking the link around this video. You answer 4 simple multiple choice questions, and it only takes 30 seconds and is 100% free. If you qualify, an accident specialist will reach out to you. All you have to do is tell them about your case and then sit back and wait until the check comes in. You could receive this life-changing check as fast as 30 days. The best part about it all? You don't pay a cent unless you win. Unfortunately, we cannot change what has happened in the past, but we can help you get a major cash settlement for medical bills, missed work, and property damage to help you get your life back on track. What would an extra $10,000 or even $100,000 do for you right now? Imagine paying off bills, covering rent with ease, or finally having some breathing room, all from money that could be rightfully yours. If the accident wasn't your fault, why should you be the one struggling? Insurance companies hope you never check what you're truly owed. But here's the truth. Most people walk away with way less than they deserve, or worse, nothing at all. Still wondering if this applies to you? If your accident happened within the last year and wasn't your fault, you could qualify for a major payout. But time is running out. These cases don't stay open forever. If you wait too long, you could lose your chance to claim what's yours. Click the link around this video, answer just 4 simple questions, and find out what your case is really worth. It's fast, free, and you won't pay a cent unless you win. But do it now, because if you wait too long, you might be walking away from life-changing money.
Okay, fatigue and increased sleeping is common in the first trimester, but in the third trimester, insomnia is often associated with just physical discomfort, not being able to get comfortable. So what it's saying here is, what else? She's complaining of that, but what else? This doesn't need to be reported. So what else do we need to report? Leg cramps relieved by stretching. That's a pretty common expected finding. Perineal pressure when standing. Y'all, you got the baby pressing on the perineum. They're going to feel perineal pressure. It doesn't feel good. Spider veins appearing on the legs. Y'all, that's expected during pregnancy. It's increased plasma volume. And that's what happens. Vaginal bleeding and abdominal pain. Y'all, you do not expect vaginal bleeding and abdominal pain. Okay, we're going to report that for sure. For sure. Now, what I don't want you to say is, well, doesn't the doctor need to know about everything? Okay, there's a difference between charting something, right? Charting something so the doctor can see it and they see the assessment that you made, and actually saying to the doctor, hey, I got to tell you, they're having this unexpected finding. One of the main things that the National Council of State Boards of Nursing wants to know is, can you identify changing assessments that are bad changes, trends in the wrong direction, and unexpected findings? If you know to look for those 3 things, you're going to get probably a third of the questions right on the NCLEX. There's going to be a ton of questions and like that. And people always put comments, under my videos. Is this really the way the NCLEX questions are? Pretty close. I don't write for the NCLEX, but I'm telling you, these are very, very close to the way you're going to get. When I write these questions, I try to make them as little amount of information as possible, because that's the way the NCLEX is. They're very vague. They give you very little information, and then they expect you to write an answer, and you have to be able to know the rule that you're using when you answer the question. A client at 30 weeks gestation expresses fear about the upcoming labor and worries about losing control during delivery. Which response by the nurse is more appropriate? This is very common. Women, especially their first delivery, they're worried about how their body's going to look. They're worried about how their partner's going to see them. They're worried about pain. How is this going to be managed? Am I going to be able to make it? So it's a very common thing. So the answer to I'm going to read the answers, but I'm looking for the therapeutic response. Therapeutic response. Okay. Now, if there's no therapeutic responses and all of them are just presenting facts, then we'll have to reassess the question. But I'm looking for the therapeutic response. Let's discuss what aspects of labor concern you the most. Labor is a natural process that women have been going through for centuries. You should attend childbirth classes to learn what to expect during labor. Focus on enjoying the rest of your pregnancy.
What if one day could change everything?
When Jesus died on the cross, it counted for all.
You have a kingdom to advance, and you have a battle to win.
Whether you're looking to get more out of your faith, your finances, or your impact on this earth, this is for you.
You were born to do something great with your life.
Real wisdom, real tools, real transformation. This is Life Surge. Experience the extraordinary. Get your tickets today.
It's definitely worth the price. You get quality review, good quality questions with all the quality goodness of, the NCLEX questions as preparation for taking the test.
Okay, B and D discount what she's saying. She's telling you about a fear, and you're kind of brushing it aside. Oh, it's just a natural process. Don't worry about it. Oh, focus on something else, right? B and D does not address her concern. A is encouraging her to talk about it, which is therapeutic. That's therapeutic. Now, C might be helpful, but there's two things about C I don't like. I don't like the word should. You should attend. That I don't like that word. That's a red flag word for me. And it's putting off her concerns. So instead of saying, I'll talk with you about it, because one of the things about therapeutic communication is addressing their concern now instead of saying, let's talk about it later. Now, if there's no option to talk about it now, then you'll have to choose talk about it later. But if there's an option to talk about it now, that's your most therapeutic response, unless it's just an inappropriate statement. But A is a very therapeutic response. It's encouraging her to talk. So when you get a question that is a therapeutic communication question, look for the answer that encourages the patient to express how they feel. All right, that's a pretty good rule of thumb. Are there exceptions to that rule? There's always exceptions, but I'm telling you, you're going to get more questions right than wrong as it relates to therapeutic communication if you encourage them to talk about how they feel. A pregnant client in her third trimester reports frequent nighttime urination disrupting her sleep. What is the best nursing response? Limit your fluid intake throughout the day to reduce urine production. Use the restroom before bedtime and consider limiting caffeine intake. Avoid drinking fluids after dinner to decrease nighttime urination. There's not much you can do. Frequent urination is unavoidable at this stage. All right, frequent nighttime urination or frequent urination is expected because of the baby's pressing on the bladder. So the bladder just can't hold as much urine before you feel like you got to go. Okay. However, does that mean I say, out of luck, you're just going to have to get up at night? No, I'm not going to say that. So D is out. I'm not going to say that. Now, limit your fluid intake throughout the day. A, I don't like that. They have increased plasma volume. They actually need to increase their fluid intake because they have a need for increased plasma volume. They increase their volume by a third when you're carrying a baby. I mean, it's a huge amount, and you don't want to limit your fluid intake. So I'm crossing off A. That's just not a good answer. So would it be better to use the restroom before bedtime and limit caffeine, or avoid drinking fluids after dinner to decrease nighttime urination? So B, I don't like because I don't know that they even drink any caffeine. Do not assume they're doing something bad unless they tell you they're doing something bad. Don't assume that they're drinking caffeine. Don't assume they have a lot of salt in their diet. Sometimes those are the right answers, but let me tell you what, I've told you this before, the right answer is the right answer because of the other answers. If absolutely everything else was a bad answer, I could pick B. If everything else was a bad answer, but everything else is not a bad answer. A and D are bad answers, but C is a good answer. C is your classic answer for decreasing nighttime urination. That's what the same thing we teach men who have an enlarged prostate and have to get up at night and go to the bathroom. We say avoid drinking fluids after dinner. Y'all, this is a fundamental question wrapped up in a maternity scenario. They're testing whether you know how to teach people to avoid nighttime urination because it's the same exact teaching, no matter the underlying cause, if we want to reduce nighttime urination. So, okay, during a prenatal visit at 6 weeks gestation, a client complains of irregular contractions that become more noticeable in the evening. What is the nurse's best explanation? Irregular contractions. So irregular contractions does not mean they've gone into labor. Okay, regular contractions. If she says I'm having regular contractions that are 20 minutes apart, I'd go, sounds like you've gone into labor, but that's not what she said. Irregular contractions that are more noticeable in the evening, which means after they're tired. Okay, and that's the kind of definition of Braxton Hicks. These are Braxton Hicks contractions, which are normal and help prepare your body for labor. That's a true statement. You may be in early labor. You should go to the hospital immediately. That's not true. Irregular contractions does not mean early labor. Irregular contractions indicate fetal distress. We'll need to monitor the baby closely. No, that's not what it means. You should avoid all physical activity to prevent these contractions. Absolutely not. Don't tell someone to avoid all physical activity. Now, we might put somebody on bed rest if they're in preterm labor or preeclampsia. Preterm labor, preeclampsia, we're going to probably do bed rest, but she's not in preterm labor. There's no evidence she's having preeclampsia. So I'm going to teach her what's going on. Those are Braxton Hicks. A client at 32 weeks gestation is experiencing leg cramps at night. Which recommendation should the nurse provide to alleviate this discomfort? Increase your intake of dairy products to boost your calcium levels. Okay, hypocalcemia is not a cause of leg cramps. It could be hypokalemia, possibly. Sometimes that can cause leg cramps, but not calcium. Massage your legs with warm oil before bedtime to improve circulation.
Why are these auto insurance ads lying to you? I'm a car insurance agent, and I've been in this industry long enough to call out the nonsense. These ads that promise you dirt cheap coverage, it's all smoke and mirrors. Today, I'm setting the record straight. The truth is, there are official programs that can lower your car insurance premium to just $38 a month, but only if you're 50 or older. Yep, if you're 50 or over, you could qualify for full coverage for as low as $38 a month. But that's the only catch. If you're under 50, this isn't for you. Anyone telling you differently is feeding you lies. There's no way to get those ridiculously cheap rates unless you're a senior. So, those ads claiming $38 car insurance for everyone, don't buy into it. They're just trying to trick you. But if you are 50 or older and want to take advantage of this $38 car insurance, scan the QR code on the right and see if you qualify. Time's ticking.
Yeah, I've never heard of that before. Maybe if all the other answers are bad, I guess maybe. But I've never heard of that before. Flex your foot upward when a cramp occurs and consider moderate exercise. Okay, I can just tell you from experience that works. So I very seldom like to answer questions based on my own personal experience, but I know C works. So I'm going to keep it on my list. Reduce your potassium intake by avoiding bananas and oranges. All right, I don't like that answer because it could be hypokalemia. And if I reduce potassium intake, that's not helping. So I'm crossing off A and D. So B is something I've never heard of before. And C is something I have done before. I think probably everybody's done that before. You get a Charlie horse in the middle of the night. That's what we call it in the US. When you get leg cramps at night, call it a Charlie horse. I have no idea where that word came from. But anyway, so I'm picking the one that I've heard of before. So what I'm talking about is using common sense. This is just common sense. This is not something I learned personally. And there's two answers that are clearly wrong and one other answer that I've never heard of. So could I have answered this incorrectly? Could I have gotten it wrong based on the reasoning that I used? I could have gotten it wrong based on my reasoning, but at least I have a reason. I have a reasoned way of answering this. I'm not just guessing. So that's what you want to do. You want to have a reasoned way of answering questions. Don't just guess, and use your common sense. At 33 weeks gestation, a client expresses fear about the upcoming labor, and concerns about pain management. Which symptom reported by the client should be immediately communicated to the healthcare provider? All right, I'm not sure where this question is going. They have fear about the upcoming labor and concerns. Which symptom should be reported immediately? Okay, sensation of pelvic pressure and lightening. No, it's a little early for that, I guess. Pelvic pressure at 33 weeks. That might be a little early, but there's nothing really concerning about that. It could happen 5 weeks before they deliver. Braxton Hicks contractions after physical activity. No, I'm not worried about that. Difficulty finding comfortable position to sleep. No, that's expected. Sudden weight gain 5 pounds in 1 week. Yeah, I'm concerned about that. Now, I've told you that if you get a complications question as it relates to pregnancy and labor, it's probably going to be preeclampsia or postpartum hemorrhage. And I'm really harping here on preeclampsia, but sudden weight gain, sudden edema, persistent headaches, protein in the urine, high blood pressure. These are symptoms of preeclampsia. So you need to show the National Council of State Boards of Nursing that you have enough sense that when someone complains of something that sounds like preeclampsia, that you need to follow up on that. During a routine prenatal visit at 35 weeks gestation, a client mentions she has developed spider nevi on her face and chest. Which accompanying symptom is cause for concern and should be reported? So basically, it's saying to you that she's got spider nevi, and that's expected. They are. Spider nevi are expected in the 3rd trimester. So that's an expected discomfort. What is unexpected? Because we report unexpected findings. Severe right upper quadrant pain. Okay, don't expect that. Nosebleeds. Nosebleeds can occur. They have increased plasma volume, increased pressure, just kind of in their body. That's why they get varicose veins and spider nevi. So yeah, that's expected. Heartburn after eating spicy foods. Well, that could happen to anybody, but yeah, certainly when you're pregnant. Braxton Hicks contractions in the evening. That's when they most often occur because you're tired. They're tired. So I am most concerned about severe right upper quadrant pain. Now, just so that you know, there's a type of preeclampsia, a very serious type of preeclampsia that can cause an enlarged liver. I'm not going to go into all the pathophysiology of it because you don't need to know all that, y'all. You don't have to bog your brain down with all kinds of pathophysiology information that you don't already know. You just want to focus on the facts that you need to know and testing strategies. So severe right upper quadrant pain, the liver's in the right upper quadrant. And so if they have liver pain when they're pregnant, I would be concerned about that because that can be associated with a very specific type of preeclampsia that is quite serious. A pregnant client is worried about losing control during labor and delivery. Which nursing action is most appropriate to help alleviate her fears? There should not be quotations around these. These are not statements. These are actions. Okay. Nursing action is most appropriate to help alleviate her fears of losing control. So remember, I said you want to get people to talk about it. But if the option to get her to talk about it isn't there, then you have to reevaluate. So let's see what answers are there. Encourage her to create a birth plan outlining her preferences for labor and delivery. Advise her to leave the decision-making to the medical team to reduce stress. Suggest she avoid thinking about labor to decrease anxiety. Tell her that labor rarely goes as planned, so flexibility is important. All right, there's no option to encourage her to talk about her fears. Since there are no options to encourage her to talk about her fears, we're going to have to look for something else. Now, is there anything here that we just don't like? Well, I don't like C at all. Suggest she avoid thinking about it. Yeah, that's not therapeutic at all. Advise her to leave all the decision-making to the medical team. In the U.S., y'all, if you're testing outside the U.S., you may not realize in the U.S., autonomy is all one of the highest American values. And so we don't ever tell people to leave it to somebody else. So B is a bad answer in America. So we're crossing off B, we're crossing off C. Tell her that labor rarely goes as planned, so flexibility is important. I mean, that's not really true. Usually labor goes as planned. I mean, it may go a little faster, but it usually goes as planned. I don't think that's a true statement. A, encourage her to create a birth plan outlining her preferences. That's something that we're now encouraging people to do. If you don't know that, we're encouraging women to create a birth plan. So they bring that in with them to the hospital so that the caregivers can follow their birth plan. For example, they may resolve, I don't want any pain medication. So that goes in their birth plan, and the caregivers are supposed to follow that. They may say, I do want pain medicine. Well, then they're supposed to follow that. They may say, I don't want an epidural. I do want an epidural. Well, then they have to follow that. So there should be a birth plan that can help increase their sense of control, which she said she's concerned about. So that is an appropriate thing. If there's no option there to get her to talk about her fears, then I like A. A client who's 36 weeks gestation calls a prenatal clinic to report their water broke. What is the nurse's best response? So 36 weeks is just a little short of full term. 37 weeks is full term. So their water broke. Okay, if you don't know this, the water, quote unquote, is used to protect the baby from infection. So when the water breaks, it increases their risk for infection, but it doesn't mean they've gone into labor. Regular contractions means they've gone into labor. Okay, that's what tells you they're gone into labor is regular contractions. So what is the nurse's best response? You've gone into labor. No, that's not what it means. Come into the clinic so we can assess you. Well, yeah, for sure. I mean, the baby's at risk for infection now. So yeah, come on in. Come to the hospital so we can prepare for a C-section. I don't mind them going into the hospital, but I don't know why we would be preparing for a C-section. There's no reason to prepare for a C-section, especially when they're preterm. We do not like to deliver preterm if we can avoid it. Stay on bed rest at home until you're full term, and then we will schedule a C-section. Okay, that's not the best response, right? I want to assess her. We want to assess her because if we assess her, we're like, you're right, your water broke, baby's at risk. Let's go ahead and admit you. Maybe we're going to start her on antibiotics 3 times a day or something. I don't know. I mean, I'm not an expert on this, but my guess is they would admit her and monitor her, give her antibiotics to prevent any kind of infection from the water breaking, and wait until she goes into labor or induce labor when she's full term, depending on kind of the provider and the mom and their birth plan and all that kind of stuff, right? So, okay, that is that. I hope you found the dangers and discomforts of pregnancy helpful to you. There's a reason why I did the video right before this series I did the prioritization video where I talked about the unexpected finding. And then I went into these dangers and discomforts of pregnancy so that I could show you how you can use that prioritization strategy. And also so that I could teach you along with the blue book about the dangers and discomforts. The dangers are the unexpected things. The discomforts are the expected things. All right. So I hope this was helpful to you. You can buy the Blue Book on Amazon. You can get the Blue Book app at clinicreviews.com. Hope you have a great rest of your week or the weekend or evening or day or whatever it is for you. Love you guys. Bye.
The truth is, not every child gets the chance to go to the movies. In North America alone, more than 20 million kids may never step inside a theater. But together, we can change that. I'm Phil Cunningham, creator of David. Our goal is to help 1 million kids experience David in theaters for free, because when a child sees this story, it plants courage and faith that ripples into their homes, their schools, their friendships. 1 million kids inspired means an entire generation changed. Go get your tickets today for free at angel.com/David. When you get your tickets and help fill those theaters, you're helping a child experience their very first movie on the big screen. Imagine if David was that movie. Thank you so much.
Hello, Clinic Review family. It's Dr. Sharon, and today we're continuing on with dangers and discomforts during pregnancy. Today we're talking about the second trimester, and so I'd stick around and watch this. You could definitely have it on your NCLEX. Let's get started. Hello, Clinic Review families. Dr. Sharon with Clinic Reviews. Thank you for being part of our Clinic Review family. You know that this channel is a part of the greater Clinic Review organization. You can go to clinicreviews.com to sign up for one of Mark's phenomenal NCLEX reviews. Y'all, I do not teach on this channel what Mark teaches in his NCLEX review. So this channel is not a substitution for his NCLEX review. This channel is a supplement to that. It's also being offered to you for those of you who cannot afford to do his NCLEX review. That's part of the reason I'm doing this, but I don't want you to think that I'm teaching what he teaches in his NCLEX review. Clinic Reviews also offers monthly small group tutoring bundles as well as a streaming service. Today, we're continuing on with our walk through the Blue Book. The second trimester dangers and discomforts is in the Blue Book. And that's what we're talking about. We already did the first trimester, and I didn't really want to make an hour-long video. I just wasn't in the mood to sit here for that long and do that. So that's why we've broken them up. The next video is going to be third trimester dangers and discomforts. So let's go ahead and get started. You know that when I teach what's in the Blue Book, the Blue Book is facts, right? It's content that you have to know. I don't teach it the way it's taught in the Blue Book. You get the Blue Book, you study the facts. What I'm doing is I'm writing NCLEX questions that go along with the Blue Book so that you can supplement that information and you can learn it and understand how to apply it in NCLEX questions. Client at 22 weeks gestation reports to the nurse that she has been experiencing frequent headaches and occasional dizziness. Which action should the nurse take first? All right, 22 weeks. So second trimester is 13 to 25 weeks approximately. So we've got a patient who's having headaches, and I say to myself, well, headaches is actually an expected discomfort, but I don't expect dizziness. So let's see what my options are. Advise the client to rest and apply cold compress when headaches occur. Well, that addresses the headaches. Instruct the client to monitor her blood pressure and report elevated readings. So I think what they're saying there is they're suspecting preeclampsia. So some of the symptoms of preeclampsia are headaches and dizziness. Those are possible symptoms. So, okay. So that actually addresses both things. Reassure a client that headaches are a common discomfort during the second trimester. That's a true statement, but it only addresses the headaches, not the dizziness. Encourage increased fluid intake to prevent dehydration. Well, there's no reason to think they're dehydrated. So we're going to cross off D. Now, one thing I've learned is that when I'm answering a test question, I want to address all of the issues in the question. So there's headaches and dizziness. A and C only address headaches. And it is true that headaches are common discomfort of pregnancy, but the dizziness is not. And when you combine the headaches with the dizziness, it could possibly be preeclampsia. And to know if it's preeclampsia, you got to check your blood pressure and do your analysis. So I have to pick B because I have to pick an answer that addresses the entire set of problems, not just one of the problems that she's complaining about. During a prenatal visit, a client at 18 weeks gestation expresses concern about dark patches that have appeared on her face. What is the nurse's best response? Okay, 18 weeks, again, that's second trimester. This is known as cloasma and is a normal finding during pregnancy. So that's a true statement. It is dark patches on the face is cloasma, and it is a normal finding during pregnancy. You should reduce your exposure to sunlight to prevent further darkening. I don't know that that was going to help. It could help. So maybe we can put a question mark next to it. We'll schedule you for a dermatology consult to assess the patches. That's not necessary. It's an expected finding. It's a discomfort of pregnancy. This could indicate hormonal imbalance. That's not true. So we're going to cross off C and D. So the question is, what is the best response? So if I can only say one thing, do I want to say, hey, this is normal, you don't need to worry about it because it's not harmful to you? Or do I not want to tell her it's normal, just tell her to reduce her exposure to sunlight? Well, I would rather tell her it's normal because she's worried about it, right? She's worried about it. So I got to tell her it's normal. So A is my best response. Do I want to talk about sun? Maybe. I mean, I don't think that's really a major issue. And I don't even know that she's exposing herself to sunlight. So I'm advising her to do something that I don't even know that she's doing. So A is my best response. At a routine prenatal visit, a client at 20 weeks gestation mentions that she has been craving and eating ice and clay. Which action is the most important for the nurse to take? So eating clay or dirt is called pica. Eating ice is also an indication of anemia. And it would not be unusual for someone to become anemic when they're pregnant because their plasma volume increases significantly, which can dilute their hemoglobin, and the hemoglobin can drop. And so eating ice and clay, now I'm not saying it's normal to eat clay, but there's a craving for that, okay? Document the cravings as a normal part of pregnancy. Well, it's not really normal. It may not be unexpected, but it does indicate a underlying problem. So I don't want to necessarily say it's normal. Suggest substituting unhealthy cravings with nutritious snacks. I don't know that that's addressing the underlying problem. Assess the client for signs of anemia, notify the provider. That sounds like a good idea. Explain that these cravings will subside in the third trimester. Well, probably not if we don't address the underlying problem. So we are going to tell the provider about this. It may not be completely unexpected, but it is more of a complication of pregnancy. So there's symptoms, expected discomforts, and then there's complications that we have to address. So nurses can address symptoms, nurses can address expected findings, but we have to report unexpected findings or complications. So we do have to report this one. During a prenatal visit at 20 weeks gestation, a client expresses concern about not gaining any weight over the past 4 weeks. What is the nurse's best response? Well, in the second and third trimester, they're supposed to gain 1 pound a week, and they have a monthly appointment until week 28. So they should have gained 4 pounds plus or minus 3. So they could have gained anywhere between 1 and 7 pounds. Okay, so anywhere between 1 and 7 pounds. They haven't gained any weight. I am a little concerned about this. So let's see what the answers are. Weight gain can vary, but we should assess your diet and activity level to ensure you're on track. Okay, so what is the nurse's best response? Weight gain can vary, but we should assess your diet and activity level to ensure you're on track. Well, that's true. That is true that weight gain can vary, and we should assess your diet and activity level. It's normal not to gain weight during the second trimester. You'll catch up in the third trimester. That's not true. They should be gaining 1 pound a week. As long as you feel fine, there's no need to worry about your weight gain. That's not true. You should increase your caloric intake by 500 calories per day to promote weight gain. Well, I don't know what she's eating, so I can't say D until I've done A. So I'm going to cross off B and C for sure because those are not true statements. A is a true statement. I am concerned about it, but I'm going to have to see what she's eating and what her activity level is like before I make recommendations. So even though it's not a first question, so sometimes first and best answers are not the same, and sometimes first and best answers are the same. And in this case, A is really the best thing to do, as well as the first thing to do. A client at 20 weeks gestation is concerned about visible stretch marks on her abdomen and thighs. Which response by the nurse is appropriate? So striae are stretch marks. Those are expected. So let's see. Stretch marks are permanent, but they'll fade to a silvery color after delivery. Well, that's true. Applying vitamin E oil daily can prevent new stretch marks from forming. Maybe. This is an abnormal finding. We need to evaluate your skin's elasticity. That's false. You can undergo laser treatments now to reduce their appearance. That's untrue. That's false. So I'm going to cross off C and D.
Contact local agent Don Wagner for an auto quote today.
So which is appropriate, to tell her, to give her a true statement, the stretch marks are permanent, but they'll fade, or to tell her that she can apply vitamin E oil daily? So I've told you this before. I say, don't pick an answer you're unsure about over an answer you are sure about. And I am sure that A is a true statement. So I'm going to pick A because I am sure about that. Now, I want to tell you why I put this question in here. I put this question in here because I want to teach you something. NCLEX will only choose treatments that are evidence-based. There has to be an evidence base for them. And that's why we can kind of be sure in telling you like what are evidence-based interventions, and we teach those and we say these are safe answers on the NCLEX. And giving a true statement is always a pretty safe answer on the NCLEX. A is a true statement. So here's the deal. B is not evidence-based. There's some thought that it could help, but there's no literature, there's no evidence to support it. And NCLEX does not like answers that lack evidence base. That's why NCLEX does not like supplements. They don't like over-the-counter treatments, generally speaking, that aren't evidence-based. So vitamin E oil, that's why you and I don't, like, I don't know, maybe that helps, maybe it doesn't, because there's no evidence base. If there was an evidence base, you would have been taught it in school to recommend that. But we don't know that. So we are going to give her the true statement. Now, if she says to me, can I put out vitamin E oil on? I would say, sure. That's safe. You can do that. And if she said to me, was it going to get rid of my stretch marks? I'd say, no, it's not going to get rid of your stretch marks. Is it going to prevent me from getting new ones? Well, there's some evidence that moisturizing does help, but I don't know that vitamin E is necessarily going to help, but you can try it if you want to. So that's what I'm saying is we can't tell somebody that something is going to prevent something unless we know for sure that it's going to do that. During a prenatal class, a client at 21 weeks gestation asked why she's experiencing heartburn frequently. What is the best explanation by the nurse? Heartburn is a sign of impending labor. You should prepare accordingly. I hope not at 21 weeks. No, that's not true. It is likely due to your diet. You should avoid spicy and fatty foods. It could be. I don't know that they eat spicy and fatty foods. It's good to tell them to avoid those, but I don't want to say heartburn's because of her diet. I don't know what her diet is. This is unusual in the second trimester. You should see a gastroenterologist. That's false. It's very common. It's a common discomfort of pregnancy. Your growing baby is pressing on your stomach, causing acid reflux. Absolutely. That is absolutely true. That's the best explanation. Now, should she avoid spicy and fatty foods? Sure, but I don't know that she's having spicy and fatty foods. Maybe she's a vegetarian and she's like, I don't have anything bad. So why would I recommend B when I don't know what her diet is? But I do know for sure that acid reflux is a common discomfort of pregnancy in the second and third trimesters because it's the baby pressing on the stomach. A client at 19 weeks gestation reports feeling pelvic pressure and occasional sharp pains on one side of the lower abdomen. Okay, pelvic pressure and occasional sharp pains on one side. What should the nurse explain to the client? These are Braxton Hicks contractions are normal at this stage. That's not true. That's not what Braxton Hicks. Braxton Hicks are false labor, and they do tend to happen more regularly. And so it's not just occasional pain on one side. That's not what a Braxton Hicks contraction is. You might be experiencing round ligament pain, which is common. Okay, round ligament pain is a common discomfort of pregnancy in the second trimester, and this is how they feel. They feel like pressure and occasional sharp pain on the lower abdomen. This could indicate preterm labor. You need to be evaluated immediately. No, preterm labor is regular contractions. Pelvic pressure is a sign of urinary tract infection. We'll need a urine sample. Pelvic pressure, is that an indication? Not usually. I mean, the frequency is an indication of urinary tract infection. Burning with urination is an indication of urinary tract infection, but pelvic pressure alone is not. And certainly occasional sharp pains on one side of the lower abdomen is not consistent with the UTI. So the only answer that's consistent with the symptoms that she's complaining of is round ligament pain. Okay, so that's the correct answer. So I'm teaching you what round ligament pain is. That's what I'm teaching you. And I'm teaching you it's an expected discomfort of pregnancy in the second trimester. A client at 20 weeks gestation comes to the prenatal clinic for a routine checkup, which findings should be reported to the healthcare provider. So we're looking for the unexpected finding, increased pigmentation of the areola and vulva. That's expected. That happens definitely during pregnancy, and it starts to happen in the second trimester. Occasional headaches relieved by rest. That's common. Again, I've told you this, it's common all the way through pregnancy. With it actually tends to get less common as the pregnancy goes along, but it's common with all the hormonal fluctuations. Sudden swelling of the face and hands. So I don't like the word sudden. We had a question in the previous video where I said they had swelling in their ankles at the end of the day. And I said that's expected because of increased plasma volume. But sudden swelling of the face and hands, that's not at all the same thing. That's an indication of preeclampsia. So I don't like that. Feeling fetal movements. Fetal movement starts in the second trimester. So I'm going with, I have to report the unexpected finding, which is sudden swelling of the hands and face. At a prenatal appointment, a client at 23 weeks gestation is concerned about visible veins on her legs becoming more pronounced, which is a result of increased plasma volume. What advice should the nurse provide? So we have varicose veins. That's what we have. And what is the treatment for varicose veins? Y'all, it doesn't matter if they're pregnant or not. The standard treatment for varicose veins is pressure. okay, and elevation of the feet. That's the standard treatment for varicose veins, whether it's pregnancy or some other reason, fluid volume overload, which is pregnancy. Wear compression stockings and avoid standing. Absolutely. Classic teaching for varicose veins. This is temporary. The veins will disappear after delivery. Sometimes they do, sometimes they don't. I would not tell them it's temporary because it might not be. Increase your vitamin K intake to strengthen your blood vessels. That doesn't do anything to strengthen blood vessels. Limit your physical activity to prevent further vein enlargement. Actually, walking activity, standing still is bad because you have venous pooling, but when you're walking, you actually have an increased muscle pump and it actually pushes the blood back to your heart. So activity is not a bad thing, but you do want to avoid standing for long periods of time, and we do recommend compression stockings. A client at 18 weeks gestation tells the nurse she feels pelvic pressure and notices varicose veins forming. Okay, pelvic pressure and varicose veins forming. So those don't seem that concerning to me. Which accompanying symptoms should be reported to the healthcare provider? So I don't think it's saying these are all related. I think it's saying, look, they come in at 18 weeks, they're in for their 18-week appointment, which isn't a typical appointment, but they're there for their 18-week whatever. And they say pelvic pressure, and I go, that's okay, that's expected. Varicose veins, that's expected. Wear compression stockings, elevate your legs when you're sitting, don't stand for long periods of time. And then they say, what else? What then should be reported? So leg cramps at night, shortness of breath while resting, pulmonary erythema, or oily skin and acne. So oily skin and acne is an expected discomfort, so to speak, of pregnancy. Pulmonary erythema, I don't know why, y'all. Pulmonary erythema is also a symptom of liver disease, but and it may be the enlarged liver. It may be an enlarged liver issue, which does get bigger with increased volume in pregnancy. So maybe that's why they get pulmonary erythema, but pulmonary erythema is expected. Leg cramps at night. Leg cramps at night, that's not, I've never, ever known of leg cramps at night being a emergency symptom. I've just never heard of it before. Whereas shortness of breath while resting, that doesn't sound good. Shortness of breath with activity, she's a second trimester, third trimester, they often get short of breath with activity, but while resting, I'm concerned about that. I don't like that. So that's the one I'm going to report. Even though I don't necessarily know that leg cramps at night is okay, I've never heard of it being a problem, and I'm not going to decide now that it's a problem when I know shortness of breath while resting is a problem. Okay, I know that. I'm not going to pick the answer I'm unsure about over the answer I am sure about. During a routine visit, a client at 25 weeks gestation reports feeling occasional heart palpitations. What is the nurse's best response? You should reduce your caffeine intake to alleviate palpitations. So this is like the other questions. I'm telling them what to do before I know more. I'm telling them what to do when I don't know that they're having spicy foods. I'm telling them to reduce their caffeine when I don't know what kind of caffeine intake they're having. I'm telling them to increase their caloric intake when I don't know what their caloric intake is. You can't make that recommendation unless you know that they're ingesting caffeine. We'll need to schedule an electrocardiogram to assess your heart function. This could be a sign of anemia. Let's check your hemoglobin levels. Heart palpitations are common due to increased blood volume during pregnancy. That's actually a true statement. It is an expected discomfort during pregnancy. We shouldn't need to do an ECG. It really doesn't have anything to do with anemia. So it is an expected discomfort during pregnancy. Second and third trimester because they've increased vascular volume. A client at 26 weeks gestation has gained a total of 10 pounds since her last visit 4 weeks ago. Which assessment is most important for the nurse to perform next? All right, so she should be gaining 1 pound a week. So if her last appointment was 4 weeks ago, because up until 28 weeks, it's a monthly appointment. So in 4 weeks, she should have gained 4 pounds plus or minus 3. So she could have gained anywhere between 1 and 7 pounds. So she really is outside the norm. She's gained more weight than I would expect her to gain. So what do I want to do next? Measure the client's fundal height to assess fetal growth. Maybe check the client's blood pressure and test urine for protein. Well, that's testing for preeclampsia. And weight gain, water retention, weight gain is a sign of preeclampsia. So that seems like a good idea. Review the client's 24-hour dietary recall for excessive caloric intake. That sounds like a good idea. Assess the client's activity level and recommend increase exercise. Well, I don't want to recommend increased exercise until I know what's going on. So I'm going to cross off D. Fundal height, fetal growth, that doesn't seem like the first thing I'm going to think of. Okay, that's not what I'm thinking of. Maybe eventually, if I rule everything out, I'll do that. So I'm going to cross off A and D. So would I rather assess her diet, or would I rather check to see if she has preeclampsia? Is there any chance she could have preeclampsia with a 10-pound weight gain in 4 weeks? Y'all, there is a chance. So if I want to show the National Council of State Boards of Nursing that I understand that I have to assess for the highest risk problems first, then I want to choose B. Because if her blood pressure is fine and there's no urine protein in her urine, then I can go on and go, okay, let's talk about your diet. Let's talk about your activity level. Because C and D kind of go together. Like I would want to do activity level and diet. So how can I say one? I can't say C or D is more important than the other one. So my biggest risk is preeclampsia. So got to do B first. Okay, that's second trimester. I hope you learned some things. I hope you learned some vocabulary particularly. And the next video is going to be dangers and discomforts of pregnancy. Third trimester. I'll try to get that out as soon as I can. I hope you have a great rest of your day. Thanks for being a part of our family.
Your talent, your style, your book. Dorrance Publishing. Helping authors since 1920. We accept manuscripts in all genres. Full-service publishing, book production, writing coach, manuscript development, promotion, and distribution. Rated A by the Better Business Bureau. Our books are printed in the USA. Manuscripts wanted. Get in touch with us for a free guide. All our consultants are located in the U.S. For over 100 years, we have been fulfilling dreams of becoming published. Become a published author with us. Dorrance, book publishing and promotion. Get your book published.
Hello, my friends. It's Dr. Sharon with Clinic Reviews. Today, I'm going to be continuing going through the Blue Book. This is the first trimester of pregnancy. It's actually in the Blue Book. It's under dangers and discomforts of pregnancy. And it's even more than that because we're going to be using the prioritization strategies that we learned in my last video when it says, which of the following findings are you most concerned about? So let's go ahead and get started with that. Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews. Today, come here, Kodak. Come here, buddy. Today, my big dog is here visiting me. This is Kodak. He's my Newfoundland. Any of you have a Newfoundland? These are gentle giants. He's a big sweetie. My other two dogs, Barkley and Israel, are actually his sons. He and another of our dogs that lives in another with my daughter had puppies. So we kept two of them and they are the sweetest babies. He is a really good dog. So we're continuing to walk through the Blue Book. We're going to be doing the first trimester dangers and discomforts of pregnancy. You know that this channel is part of the greater Clinic Review organization where you can take our NCLEX review. Our NCLEX review is an online on-demand review that you can get up to 3 months. Maybe you can get longer than 3 months. I'm not sure. But Mark Klimek teaches that. And then we also have our monthly packages for small group tutoring. And we also have our streaming service. All right, well, let's go ahead and get started. This is actually some really important information. It's very fundamental and you definitely should know it. So let's go ahead and get started with it. A client in her first trimester of pregnancy visits the prenatal clinic. She reports several symptoms to the nurse. Which assessment finding is most concerning? So remember, in my previous video to this, I taught you that when they give you a patient's diagnosis and all the findings are in the answers, you always choose the unexpected finding to be most concerned about. So she doesn't have a diagnosis per se because she's not sick, but we do have something that describes her. She's in her first trimester of pregnancy. So that's the key thing. So we're looking for the unexpected finding during the first trimester of pregnancy. That's always what we're most concerned about. The client experiences morning nausea and occasional vomiting. That's expected. That's normal. discomfort of pregnancy. The client reports urinary frequency during the day and night. Y'all, that is a discomfort of pregnancy. It occurs in the first and third trimesters. Urinary frequency. The client has mild swelling in her ankles by the evening. Well, if she had sudden swelling in her ankles, I'd be concerned about. Mild swelling in her ankles by the evening is pretty common. She's having an increase in vascular volume. And so she does have more swelling. The client reports sharp abdominal pain and vaginal spotting. Unexpected, y'all. Any sharp pain is very unexpected. We don't want to see that. So that's what we are most concerned about. A client at 12 weeks gestation, which is the end of the first trimester, expresses concern about not gaining any weight due to persistent nausea and vomiting. What is the nurse's best response? All right, so during the first trimester, they're supposed to gain 3 pounds. They're supposed to gain 1 pound a month, and that can range anywhere between, they could gain up to 6 pounds probably, but between 3 and 6 pounds, maybe 2 pounds, like 2 to 6 pounds would be acceptable, but they should gain some weight in the first trimester. Not a lot, but a little bit.
I believe that all you really need is you roll to pass the NCLEX. That's what I used.
There's over 2,000 questions plus self-examinations. However, what you need to know the best is, why did I choose this answer? And read that little rationale.
Compared to other resources, I would say it's definitely the simplest and easiest to navigate. And then the questions, they're so similar to NCLEX style ones. And if anything, they might have been more difficult.
You guys get the UWorld early, start practicing early. It is worth it. They're good. It works. I promise you, first attempt at the NCLEX, pass. First attempt.
So what is the nurse's, so saying she hasn't gained any weight. So I say that's unexpected. And what do we do with unexpected findings? We have to report it to the healthcare provider. We have to intervene immediately. We're most concerned about that. So I'm looking for an answer that says, yeah, I'm concerned about that. It's common not to gain weight in the first trimester. That's false. Let's discuss ways to manage your nausea. Well, we definitely should discuss ways to manage the nausea, but the first half of that is a false statement. You should try to eat more to ensure you start gaining weight. Maybe, but she's not gaining weight because she's nauseated and vomiting. So I don't know if that's going to help. Not gaining weight is concerning. There you go. I'll notify your healthcare provider immediately. Exactly right. So it says, I'm concerned about that. I'm going to have to notify the healthcare provider. That's the right answer. Don't worry about weight gain now. It's only important in the second and third trimesters. Well, they certainly gain more weight in the second and third trimesters. They gain 1 pound a week in the second and third trimesters, but they still should gain weight in the first trimester. So my best response is to show them that I am concerned. This is an unexpected finding. A pregnant client at 9 weeks gestation comes for a routine checkup. Okay, 9 weeks of first trimester. Which assessment data should be reported to the healthcare provider? So the reason in the Blue Book, Mark calls this the discomforts and dangers of pregnancy is because discomforts are expected, dangers are unexpected. So let's see which of these are discomforts and which of these are dangers. The client has nasal stuffiness and epistasis. Epistasis or staxis, I don't know how to say it, is nosebleeds. Y'all, that is a discomfort of pregnancy. It's not a danger, it's a discomfort. So that's expected. The client reports severe dizziness and blurred vision. That doesn't sound good. So B does not sound good. That's not an expected discomfort. C, the client experiences breast tenderness and enlargement. That's a discomfort of pregnancy. The client mentions increased leukorrhea. If you don't, I use the word leukorrhea on purpose. They actually have increased white vaginal drainage. That's leukorrhea, white vaginal drainage. It actually is a discomfort of pregnancy. It's increased in the first trimester. And so that's expected. So what did I say was not expected? Well, dizziness and blurred vision is certainly not expected. So that's a danger. A, C, and D are all discomforts of pregnancy, and it is uncomfortable at times, a lot of times. So discomforts are expected, dangers are not expected. During a prenatal visit at 10 weeks gestation, which is the first trimester, a client tells the nurse she's gained 6 pounds since becoming pregnant. Which action should the nurse take first? So that's kind of the high end of normal. So I'm like, well, she's really supposed to have gained 3 to 6 pounds by week 12 or 13. So she's get close to the high end. So let's see what our answers are. Praise the client for appropriate weight gain. Maybe, if nothing else makes sense, maybe, but she seems a little high. Assess the client's dietary habits and activity level. That seems like a good idea. I don't want to necessarily tell her she's gained too much, but I'd kind of like to know how she's eating and if she's staying active. Recommend the client reduce caloric intake to prevent excessive weight gain. I don't want to do that until I know how she's eating. Document the finding as normal, continue. I'm not ready to document it as normal until I assess her dietary habits and activity level. So I'm not sure if it's unexpected or not. It's the high end of normal, so I'm going to see how she's doing before I call it a concern. A woman in her first trimester of pregnancy discusses her symptoms with the nurse. Which symptom requires immediate intervention? That means which is unexpected, okay? The client complains of fatigue and needs frequent rest periods. Y'all, fatigue is a discomfort of pregnancy, particularly in the first trimester. The client experiences mild gum bleeding while brushing their teeth. That's actually a discomfort of pregnancy, y'all. That is a discomfort of pregnancy. The client reports severe vomiting several times a day. That's a problem. A red flag word is severe. There's certain red flag words that I don't like on the NCLEX. Severe is one of them. Always, never. These are like extreme words. Those are always red flag words for me. So C is a red flag. The client mentions occasional headaches relieved by rest. That's a discomfort of pregnancy because of hormonal fluctuations. So yeah, I'm concerned about the severe vomiting. That's the one that requires immediate intervention. A nurse is educating a group of women in their first trimester about scheduling prenatal visits, which statement indicates a need for further teaching. Further teaching. I'm looking for the false statement. Further teaching, false statement. I need to schedule prenatal visits every month until I'm 28 weeks along. Regular prenatal visits help ensure my baby and I remain healthy. I should start regular appointments when I'm 10 weeks pregnant. After 28 weeks, I need to see my healthcare provider more frequently. So the rule is once a month until week 28. And in maternity language, a month is always 4 weeks. Okay. So I know in real life, a month is sometimes 5 weeks, but in maternity language, a month is every 4 weeks. So they're supposed to see their healthcare provider every 4 weeks until week 28. So 4, 8, 12, 16, 20, 24, 28. So they should see by the time they're at week 28, they should have seen them 7 times. And then they go every 2 weeks until they're full term. So every 2 weeks until they're week 36, and then once a week until delivery. So D is a true statement. After 28 weeks, I'll need to see my healthcare provider more frequently. Regular prenatal visits. B, help ensure my baby and I remain healthy. That's true. That's why we do them. And A, I need to schedule prenatal visits every month. That's true until week 28. So we don't start at week 10. We start at week 4, seeing the healthcare provider 4, 8, 12, 16, 20, 24, 28. That's the schedule. A client at 8 weeks gestation attends her prenatal appointment, which assessment finding is most concerning. So I'm looking for the unexpected finding. The client has a low-grade fever and reports burning on urination. Y'all, that's classic UTI. So UTI is considered a danger in pregnancy because that infection can move up and cause infection in the placenta. So that's a problem. The client has gained 2 pounds since her last visit. So 8 weeks. So her last visit should have been 4 weeks. Remember, because it's 4, 8, 12, 16. And they're supposed to gain about a pound a month. So she's gained 2 pounds. So she's gained a little more than she should have. But remember, it could be a little flexible with that, like a pound or so off right here or there. So I'm okay with 2 pounds. The client reports feeling ambivalent about the pregnancy. So the first trimester, very commonly, this is how they feel. They're just trying to grasp the fact that they're pregnant, especially if it's their first pregnancy. Like, it just is hard to believe because they don't really feel that much different. I mean, they feel more tired. They may have some bleeding gums. They may have some increased leukorrhea. They may have nausea, but they don't really feel pregnant, right? And so they often feel very ambivalent. So the kind of the developmental goal during the first trimester is just to accept the fact that you're pregnant. So that's kind of expected. The client experiencing mild low back discomfort after standing. Well, usually low back pain doesn't start until the second trimester, but after standing, yeah, sure. Don't we all have low back discomfort after standing for very long? Maybe not all of us, okay? But at my age, we do. So yeah, I'm more worried about the UTI, definitely. I mean, if I had to pick between A and D, I would definitely go with A. That's unexpected. A client who is 8 weeks pregnant attends her first prenatal appointment. She asks the nurse how much weight she should gain during her pregnancy, which response by the nurse is most appropriate. You should gain about 25 to 35 pounds evenly throughout your pregnancy. All right, I like that answer because it's 25 to 35 pounds, which is usually about where we say. So Climic teaches 28 pounds plus or minus 3, but 25 to 35 is right in there. So that's about right. The problem I have is it says evenly throughout your pregnancy, because it's not evenly. You gain a lot more weight in the second and third trimester than in the first. So I'm going to put a question mark next to that. Weight gain isn't important in the first trimester. Focus on gaining. No, that's not true. Weight gain is important in the first trimester. You gain a lot more in the second and third, but that doesn't mean we ignore it in the first. Your recommended weight gain depends on your pre-pregnancy body mass index. Let's calculate it together. So the reason I like A is because 25 to 35 pounds is the recommended weight gain for women with a BMI between 18 and 25. And we kind of memorize that number because we just assume women have a BMI of within normal limits, which is 18 to 25. But I do know if women are underweight, when they get pregnant, they need to gain a little more weight than that. And I know if women are overweight, they need to gain a little less weight than that. So that C makes sense to me. That statement makes sense to me. Try to limit your weight gain to no more than 15 pounds to reduce the risk of complications. That's not true. We want women to gain enough weight that they have a healthy baby. So the reason I don't like A is because it says evenly throughout your pregnancy. I like C because that is a generally true statement. Okay, well, that is all. A short and sweet video for you. I hope you found that helpful. It's actually some really important information. I know it went fast, but if you're like, yeah, that's interesting, Sharon, but I don't really know it, then watch the video again. You need to know this information. It's important for you to know. And I wish you all the best on your NCLEX and any other standardized tests you might be taking. Thanks for being a part of our family.
Why are these auto insurance ads lying to you? I'm a car insurance agent, and I've been in this industry long enough to call out the nonsense. These ads that promise you dirt cheap coverage, it's all smoke and mirrors. Today, I'm setting the record straight. The truth is, there are official programs that can lower your car insurance premium to just $38 a month, but only if you're 50 or older. Yep, if you're 50 or over, you could qualify for full coverage for as low as $38 a month. But that's the only catch. If you're under 50, this isn't for you. Anyone telling you differently is feeding you lies. There's no way to get those ridiculously cheap rates unless you're a senior. So, those ads claiming $38 car insurance for everyone, don't buy into it. They're just trying to trick you. But if you are 50 or older and want to take advantage of this $38 car insurance, click the Learn More button below and see if you qualify. Time's ticking.
Hello, my friends. It's Dr. Sharon with Climic Reviews. Today, we're talking about oral contraceptives. We're going to talk about the combination progestin and estrogen and the progestin-only pill. We're going to talk about side effects and the teaching related to those that the nurse has to do with patients. This is very likely to be on your NCLEX. So let's go ahead and get started. Hello, Climic Review family. Today, my dogs are keeping me company. I was away yesterday for 12 hours at the hospital, and so they are wanting to spend time with me today. So I've got two of them here. Come here, Bubby. Come here, Bubby. Yep. See, these two are brothers. They were in the same litter. Their mom and dad are also owned by us, and they are the sweetest little puppy dogs. This one is Barkley, and this one is Israel. All right, so that's the fun stuff. We got that out of the way. You know, this YouTube channel is a part of the Greater Clinic Review organization where you can take seriously the very best NCLEX review in the entire universe. There, Mark Klimek, the GOAT himself, teaches that review. It's online on demand, and you get access to it for, I don't know, I think you can pick how long you want, but it's like 3-4 months you can get it for. I also recommend it, by the way, if you're still in school. I do recommend taking it. It is extremely helpful for any of those standardized tests you have to take. If you're in an ATI school where all your tests are ATI or standardized tests, it's helpful with those. So it is something you may want to consider doing, even if you're in school. We also have packages for small group tutoring, monthly packages, and our streaming service. Today, we are going to be talking about oral contraceptives. So there's two different types of oral contraceptives we're going to talk about. There's the combination. The combination is progestin and estrogen. And I've already done a video on the menstrual cycle for women, or the ovulation cycle for women. And so you should already know that estrogen is present in the first 14 days. It helps stimulate the ovulation, and then progestin is present in the second half of the cycle, and that helps get the uterine lining ready for implantation. And so when you take a combination estrogen progesterone, you keep those levels at a normal level or at an acceptable level in the body, so the body doesn't think it has to secrete those things. So if the body doesn't think it has to secrete those things, then you're not going to ovulate. So the estrogen prevents ovulation, and then the progestin prevents getting the uterine lining ready for implantation. So it prevents implantation. So the combination drug does two things, and then you can take progestin only. Progestin only, generally speaking, is thought to have fewer side effects. It's the estrogen that often causes thrombolytic events, headaches, and so forth. And so so the estrogen pill is contraindicated with hypertension, with DVT, with migraine headaches, those kinds of things. So progestin can be used in those circumstances, but you take the progestin consistently. So the estrogen progestin pill is taken generally on a 7 to 7 day cycle. So 21 days on, 7 days off. So the combination estrogen progestin is 21 days on, 7 days off. So it's a 28-day pill pack. And if you've ever taken them, you know they come in these round circles, and you take it according to the day, so you can see if you missed a dose. There are other ways to take the combination pill. So you can do a 24-4 combination where you take 24 days off, 24 days on, 4 days off. It's a placebo. You can take nothing. You can take the placebo pill. That decreases, the side effects of menstruation. So you have fewer cramps, you have fewer headaches, and then they can take it where they just take it through all the way. There's no placebo pills. They're always on the hormones, and they won't ever have a period if they do that. And so there's pros and cons of both of those things, and they would look at the risk factors associated with clotting and headaches and other things to decide if they're going to put a young woman on the combination oral contraceptive. If you're asked about combination oral contraceptives on the NCLEX, you should assume it's a 21-7 day cycle, unless they tell you otherwise, because that's the most commonly prescribed method, is the 21 on, 7 days off. And then progestin is consistently on, 28 days consistently on. It can prevent ovulation. It often prevents ovulation, but that's not its primary mechanism of action. Progestin only prevents implantation, and so they're on it 28 days or constantly. There's no off days. And progestin only also has a short half-life, and so they need to be more consistent in taking it. So we recommend they take it at the same time every day. The combination estrogen progestin should be taken at the same time every day. But if they forget, they can just take it when they remember. Whereas the progestin, we recommend taking it at the same time within a 3-hour window, at the same time every day. And if they miss a dose, they actually have to use backup contraception for 7 days. All right, let's go ahead and do some questions. All right, 37-year-old woman with a history of hypertension is considering starting combination oral contraceptives. What is the nurse's priority action? Suggest switching to a progestin-only pill. Advise her to use barrier methods for birth control. Recommend a lower dose estrogen contraceptive, or proceed with prescription as planned. So she's older, which is over the age of 35. We usually don't recommend the combination oral contraceptive because the older they get, the increased risk for thrombotic events. So we don't generally recommend it for people over the age of 35. She also has a history of hypertension, which increases her risk for thrombotic events. If she was a smoker, it would be contraindicated. If she had a history of DVT, it would be contraindicated. So she has 2 risk factors. So we would suggest that she switch to the progestin-only pill. That would be a better thing for her. A breastfeeding mother asks about contraceptive options. Which oral contraceptive is most appropriate for her? Combination estrogen progestin pill, progestin only, extended cycle contraceptive, or high dose estrogen pill. So as long as they're breastfeeding, we don't recommend estrogen because it reduces the milk production. So they can take birth control while they're breastfeeding, but it's progestin only pill. And the other thing to remember is that they shouldn't be on the combination oral contraceptive in the first 4 to 6 weeks after delivery. And that's because during the first 4 to 6 weeks after delivery, they have a higher risk for thrombotic events. And so they shouldn't be on that estrogen. So they can start progestin pretty much as soon as they want to, progestin only, but they recommend not doing the combination pill while you're breastfeeding and not doing the combination pill for the first 4 to 6 weeks after delivery. A patient misses one active combination birth control pill. What instructions should the nurse provide? Take the missed pill as soon as remembered and continue the rest as scheduled. Discard the missed pill and double the dose the next day. Stop the pack and start a new one immediately. Use backup contraception for 7 days. So with one missed pill, they don't have to use backup contraceptives. They should take the pill as soon as they remember. That's the recommendation. If you miss a dose, take it as soon as you remember. If they normally take it at night and they remember in the morning, then take it in the morning and then take their pill as scheduled again that night. If they normally take their pill in the morning and they remember that evening that they forgot a pill, take it that evening and then the next morning take the morning pill as scheduled. When discussing side effects of birth control pills, which statement by the nurse is accurate regarding breast tenderness? Breast tenderness is rare and should be reported immediately. This side effect often decreases after a few months of use. It means the pills are not suitable and you should stop them. Only high-dose pills cause breast tenderness. Well, if you're a woman, then you know that the hormone fluctuations are normal and breast tenderness is normal during your hormonal cycle. And by keeping a consistent amount of estrogen in your body across a 21, 28-day cycle, you're going to have breast tenderness kind of throughout that cycle. But the thought is that it's a side effect and that it decreases after a few months of use. So that's what we teach people. During a follow-up visit, a patient reports nausea since starting combination oral contraceptives. What is the nurse's best response? Stop taking the pills immediately. This indicates the pills are not suitable for you. Double the dose every other day. Take the pill at bedtime or with food. So we recommend when pills cause nausea, because nausea is probably the most common side effect of any oral medication, we recommend taking it with food. And the reason we recommend at bedtime is so that if there's any nausea, you sleep through it. I don't know how well that works. I've given that recommendation before. I've been given that when I was younger. I don't have to worry about this anymore. But when I was a lot younger, I was given that recommendation. And it was not, I just got sick in the middle of the night. So I don't know how well it works. But on the NCLEX, y'all, it works. Okay, this works on the NCLEX. So pick it. A patient missed 3 active combination pills in the first week. What is the nurse's best advice? Take 1 pill now and continue with the rest using backup contraception for 7 days. Discard the current pack and start a new pack immediately using backup contraception. Take all 3 missed pills at once or wait for the next menstrual cycle to resume pills. So the recommendation is that when you miss 3 in a row of the combination contraception, the oral combination contraception, if you miss 3 in a row, this is the rule for 3 in a row, you discard your pack and you start over with a new pack. It doesn't just have to be in the first week. It's recommended that you throw it out and start a new pack, and you do have to use backup contraception until you get back into the normal cycle. A patient is prescribed antibiotics while on oral contraceptives. What should the nurse include in the patient teaching? No additional precautions are necessary. Use a backup contraceptive method used during antibiotic therapy. Stop taking oral contraceptives while on antibiotics, or increase the dose of oral contraceptives. So the rule is that oral or any kind of antibiotics reduces the effectiveness of oral contraceptives, and you have to use backup contraception during that period of time. If you're wondering what backup methods means, it could mean a diaphragm, it could mean a condom, it could mean abstinence, but something else. So if you don't want to get pregnant, you don't get pregnant. If a woman misses 2 consecutive active combination pills in week 2 of her pack, what should the nurse advise? So this doesn't matter that it's week 2. So I put that in there so that you could understand that it doesn't matter, so you don't get confused by that. So if a woman misses 2 consecutive active combination pills, what should she do? Take 2 pills daily for 2 days and use backup contraception. Discard the pack and start a new one. Continue taking 1 pill daily without taking the missed pills, or no additional action is required. So what that you recommend is that they take it the next day. So if you've missed 2, then on day 3, you take 1 of your missed pills, and on day 4, you take your other missed pill, and you should use backup contraception for 7 days. And it doesn't matter that it's week 2. So if you're asked the question, what if they miss a dose? The answer is take it as soon as they remember. If you're asked the question, what if they miss 2 doses? The answer is you take it with the next 2 doses. A patient asks why she needs to use backup contraception after missing 2 consecutive combination pills. The nurse explains that the hormone levels may not be sufficient to prevent ovulation. Missing pills increases the risk of side effects. It prevents the pills from causing nausea. Backup methods are only a precaution, not a necessity. So it's because the hormone levels may not be sufficient to prevent ovulation. So remember, we're keeping a steady state of estrogen in the woman's body so that the brain doesn't sense this low level of estrogen. Because if the brain senses a low level of estrogen, it's going to increase the level of estrogen, which could cause ovulation. Remember, estrogen is what precedes ovulation. So that is important, that for the next 7 days, because what if they ovulate? What if they miss 2 doses and they ovulate? When are they likely to have that egg be fertilized? Well, the egg's only good for 72 hours. So for the next, I guess you could say 3 days, but let's be safe and say 7. A patient on combination oral contraceptives reports missing her period this month. What should the nurse advise? Stop taking the pills immediately. Double the dose of pills for 1 week. Continue taking the pills and consider a pregnancy test if she misses 2 periods. Schedule an urgent appointment with the healthcare provider. So it's not that unusual to miss periods when someone's taking oral contraceptives. So look, they're welcome to go out and get a pregnancy test if they want to, but we don't recommend it because we say it's not that unusual to miss a period when you're on oral contraceptives. So continue taking the pills as ordered. And if you miss 2 periods, go ahead and take a pregnancy test. But after 1 missed period, it's not recommended. I mean, someone wants to spend the money. Pregnancy tests are expensive, y'all. So if you want to spend the money, go out and spend the money. You're going to spend like $30 on one, though, to get one from the drugstore. A patient is concerned about breakthrough bleeding after starting a new pack of pills. How should the nurse respond? You should stop taking the pills immediately. This indicates the pills are not effective for you. Double your dose until the bleeding stops. Breakthrough bleeding usually resolves after a few cycles. So this is just like nausea and breast tenderness. Nausea, breast tenderness, and breakthrough bleeding are expected side effects, and they usually resolve after several cycles. That's usually what we teach. Now, if they say, I can't handle this, I don't want to take these, fine. They can use a different method, but they are considered side effects, which means nurses teach about side effects and teach patients how to manage them. We don't call the doctor about side effects. It's our responsibility to teach patients how to manage those. Adverse effects, on the other hand, is something we do stop the medication for, and we do contact the doctor. So if they call in and they say, my right leg calf is swollen, I'm going to go, stop the med. Let's call the doctor, because that could be a DVT, which is an adverse effect of oral contraceptive use. A woman is switching from combination pills to progestin only. What important teaching should the nurse provide? You can start the progestin only pills at any time without backup. Ensure you take the progestin only pill at the exact same time every day. progestin-only pills have a wider window for missed doses. Expect fewer side effects with progestin-only pills. So the question is what important teaching? So in other words, it's a most important or best or highest priority. So when you look at those, you have to say, look, there may be more than one true statement here, but which is the highest priority? What's the goal of the pill? The goal of the pill is to prevent pregnancy, right? So we want to make sure she knows how to prevent pregnancy. You can start the progestin-only pills at any time without backup. That's actually not true. Ensure you take the progestin-only pill at the exact same time every day. That's true. Now, they have a 3-hour window, but we usually say, look, just take it at the same time every day so you don't forget, right? Because it has a shorter half-life. And so you can't, for the progestin only, you don't say, as soon as you take it as soon as you remember. If they miss the progestin only, they can take it as soon as they remember, but we recommend that they use backup contraception for several days. Progestin-only pills have a wider window for missed doses. That's false. So A and C are false. Expect fewer side effects with progestin only. That's actually true. That's one of the reasons we put women switch to progestin only, is they don't cause headaches. They don't have the contraindications with hypertension and so forth. But which is more important? So which is a higher priority? That we tell them they take it at the same time every day because that helps prevent pregnancy, or, hey, it's nice that there's fewer side effects. Actually, it's more important that we tell them B, because that's the whole point of giving the medication. And so we have to do B. Okay, so I hope that was helpful to you. I hope you have a great rest of your day, and I'll see you later. Hello, my friends. It's Dr. Sharon with Clinic Reviews. Today I'm talking about placenta previa painless, placenta previa painless, placenta previa. Say that 10 times fast. It's not easy to do. There is a difference between abruptio placenta, which I have already done, and painless placenta previa. So let's get started. Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews, the home of the very best NCLEX review in the entire universe. You can go to clinicreviews.com and you can get access to our online on-demand NCLEX review. You can also find there our small group tutoring and our streaming service. So let's go ahead and talk about placenta previa. This is in the Blue Book. You can get the Blue Book on Amazon, or you go to clinicreviews.com and you can get it as an app. All right, where do I want to start? We talked about abruptio placenta already. Abruptio placenta is where there is a separation of the placenta from the uterine wall somewhere within the uterus, and it can cause a lot of pain. The key thing with abruptio placenta is it causes pain and some bleeding. But with placenta previa, you actually have, for some reason, the placenta doesn't grow correctly, and it actually covers the part where it's supposed to be attached to the uterus, actually covers the cervix or the cervical area or the birth canal area, and it causes a lot of bleeding. But it's painless because there's no separation occurring. It's this in abruptio placenta, it's the separation that causes the pain. There's no separation in placenta previa. It's just where the placenta started to grow. And it's too low. And I'm going to show you a picture a little later. So let's go ahead and talk about placenta previa. And we'll start out by talking about just what it is. A pregnant client at 32 weeks gestation arrives at the ED reporting painless vaginal bleeding. Which condition does the nurse suspect? So what is it that leads us? Obviously, the answer is placenta previa, since that's what we're talking about today. But how can you remember that? Well, first of all, they're already pregnant. Okay, they're already pregnant and they're not having any pain. So we can cross off preterm labor because they're not having any pain. If they were having contractions, we would say preterm labor. They're 32 weeks along. So we're going to rule out ectopic pregnancy because this would have been a problem a while ago. Ectopic pregnancies don't make it to term. They wouldn't have made it to 32 weeks. They would have had a lot of pain and problems before this. So we're going to rule out ectopic pregnancy. So we're left with between placenta previa and abruptio placenta. And we have painless vaginal bleeding. So that's how you differentiate placenta previa and abruptio placenta. When they come in and it's painless bleeding, you say that's placenta previa. So I just want to make sure that you could see what I'm talking about here. Wrong picture. There we go. So you can see here in normal placenta, you have the placental wall growing out of the uterine wall high up where it's supposed to be. Then we have a marginal placenta previa, which is close to the cervix, but it's not quite there yet. And then partial, where it's partially covering it. And then total, where it's totally covering it. Okay, so that's what a placenta previa is. A client diagnosed with placenta previa is admitted to the hospital. Which interventions should the nurse implement? Select all that apply. Y'all, they're going to be admitted to the hospital if they have bleeding, okay? Bleeding. They may have to take them for C-section and take the baby early. If they can get them into the hospital and they can get their bleeding stopped, they can keep them, they'll keep them pregnant for as long as possible so that the baby can develop. But, you know, if they have to, they'll have to take that baby early because fetal demise is the problem if there's too much bleeding associated with it, right? If the mom hemorrhages out, the baby's going to die and the mom's going to die. So, client diagnosed with placenta previa is admitted to the hospital. Which intervention should the nurse implement? So we're worried about mom, we're worried about baby, we're worried about bleeding. Monitor fetal heart rate continuously. Y'all, absolutely. We're worried about baby. We got to monitor baby continuously. Perform a vaginal examination to assess cervical dilation. All right, a vaginal examination is not something the nurse should be doing with placenta previa. The doctor can come in and do a speculum exam where they actually visualize what it looks like, but we're not doing any digital vaginal exams because it could cause a lot of problems. So no, do not do B. Prepare for possible cesarean delivery. Yeah, this is a possibility. If it said prepare for cesarean delivery, I wouldn't pick it. But for possible cesarean delivery, see, I'm not the person who makes that call. So a possible one, absolutely, I need to be prepared for that. Administer corticosteroids as prescribed. Why would we do that? Corticosteroids mature babies' lungs. That's why I would do that. And I like this answer because it says administer as prescribed. So as opposed to, like, I'm not going to question the order. So if I get an order to administer corticosteroids, I'm not questioning it because I know that's the medication we give to mature babies' lungs. And if we have to take this baby early, we need to give them corticosteroids. Encourage ambulation in the hallway? Absolutely not. This is bed rest for mom while we try to prevent her from bleeding and from possibly going into labor early. We want the baby to bake as long as possible so it can be mature. The nurse is teaching a client with placenta previa about her condition. Which statement by the client indicates a need for further teaching? Further teaching means false statement. So further goes with false. So I'm looking for the false statement. So she has placenta previa. I'm looking for the statement that is false. I understand that I need to limit my physical activity. Absolutely true. I should report any increase in bleeding immediately. Absolutely true. I can expect to deliver my baby vaginally. False, y'all. Placenta previa babies are delivered by C-section. I need to avoid sexual intercourse until after delivery. Absolutely true. So, and I think you understand why that is from what I explained to you about placenta previa and so forth and what it is. So hopefully you understand that answer. Which of the following complications is the most significant concern for a client with placenta previa? So most significant concern means most common and most life-threatening. So if none of the concerns are life-threatening, then you go with the most common. But if any of them are life-threatening, you go, is this likely to happen? And is it life-threatening? And I go, that's the one that's most significant. Infection, it can happen. Preeclampsia, I mean, it can happen, but it's not associated with placenta previa. Fetal anomalies, that could happen. Hemorrhage, okay, that's life-threatening. It definitely could happen. It's associated with placenta previa, so we're going to go ahead and pick that one. In caring for a client with placenta previa, which of the following is the highest priority nursing action? So the highest priority nursing action means best nursing action. Best nursing action is that one thing that you have to do. You do not want to tell the National Council of State Boards of Nursing that you're not going to do this one thing because it's absolutely important in order to care for a patient with this problem, and this problem is placenta previa. Assess maternal vital signs every 8 hours. I don't really want to tell the National Council I'm going to do it every 8 hours because she's at very unstable. I'd rather do it every hour, every 2 hours. That's more like when I want to get vital signs. Monitor urinary output. Okay, I want to do that. That's fine. Ensure IV access is maintained. Absolutely. I want to do that, especially with a large bore IV needle, because if we have to give her blood, I need to have IV fluids there. Evaluate fetal heart rate patterns. Absolutely. I want to do that. So I do want to monitor urinary output, but that doesn't seem like the highest priority to me. A and B. So I'm going to rule out A and B. So I'm like, I have to have an IV access and I have to evaluate fetal heart rate patterns. So how am I going to choose between these two? And this is what people tell me all the time. I got down to 2, Dr. Sharon. I couldn't figure it out. This is common with high priority or best questions. So what I say is I'm going to make sure I have an IV line, but I'm not going to monitor fetal heart rate patterns. Well, that doesn't seem, I don't really want to tell the National Council of State Boards of Nursing I'm not going to monitor fetal heart patterns. I mean, what's a high risk? Fetal demise. Do I really want to tell the National Council I'm not going to monitor the baby? Or I'm going to monitor fetal patterns, but not make sure their IV access is maintained. So, y'all, I have to monitor fetal heart rate patterns. I have to do that. We can get an IV in later if we absolutely have to, but I cannot tell the National Council that I'm not going to monitor this baby's heart rate patterns when I know that fetal demise is such a high risk. Okay, so that's the correct answer. Now, when you get these priority questions or these best questions, high priority questions, there are going to be 2 answers. And you like them both, and they're both important, y'all. This is a conceptual question. It is not a clinical question, because in real life, we would make sure we did both C and D. On the test, what they're saying is which one shows that you understand what are the highest risks here. And we understand the highest risk is for fetal demise. And if we have to, we can put an IV in later. But I do not want to tell the National Council of State Boards of Nursing that I'm going to disregard fetal heart rate patterns. A nurse is caring for a client with suspected placenta previa. The client asks why cesarean delivery might be necessary. What is the nurse's best response? So I'm looking for a true statement, and I'm looking for a true statement that is, if there's more than one true statement, I'm looking for the one that encompasses any other true statement there might be. A cesarean delivery reduces the risk of infection. Well, I don't think that's true. Your baby might be in a breech position. I suppose it could be. The placenta is blocking the birth canal. That's absolutely true. You may develop a high blood pressure during labor. Could happen, but the one that I know for sure, for someone with placenta previa, why they need C-section every time, no vaginal delivery for placenta previa, is that the placenta is blocking the birth canal. Which client? Cooper. My dog looked at me like, what, Mom? I'm making lots of noise. Is that bothering you? Yes, Cooper, that's bothering me. Stop. Cooper, stop. All right, he left the room. Good. Which client is at highest risk for developing placenta previa? All right, a 25-year-old prima gravida with a history of preeclampsia, a 30-year-old gravida 3, para 2 with previous cesarean deliveries, a 22-year-old woman with gestational diabetes, a 28-year-old woman carrying twins. So the number one risk for placenta previa is multiple deliveries. And the second is cesarean deliveries. So we always pick, when it asks about risks, we always pick the person with the most risk factors. So really the only person who has risk factors is B. Which medication is commonly administered to promote fetal lung maturity in a client with preterm placenta previa? So I told you already, we use corticosteroids to mature fetal lungs. Betamethasone, y'all, if it ends in sone, prednisone, betamethasone, then it is a corticosteroid. Mag sulfate is used to stop preterm labor. Nifedipine is used to stop preterm labor. Cooper, stop. Oxytocin is used to start labor. So the only one that's used to mature lungs is betamethasone. A client at 36 weeks gestation with known placenta previa reports increased vaginal bleeding and uterine contractions. What is the nurse's priority action? So here we have someone who's 36 weeks gestation. 37 weeks is considered full term, so she's not full term yet. So she's in preterm labor because she's having uterine contractions, and she has placenta previa. So my concern is that we're going to have to take the baby a week early. So what do I want to do? Well, let me just think about this. So what I want to do is I want to mature baby's lungs, and I want to stop labor if we can. If we can't, we're going to take her for C-section. So those are my thoughts. So priority action, notify the healthcare provider. Well, I definitely want to do that. She's 36 weeks. She's bleeding and she's in preterm labor. I definitely want to notify the healthcare provider. So that's going to stay on my list. Check the client's cervical dilation. No, I'm not going to do that because that's dangerous. Prepare for emergency cesarean delivery. Yes, I probably do want to do that. Administer tocolytic medications as prescribed. Tocolytic medications stop labor. All right, so I have really, honestly, 3 things here that I could do. Notify the healthcare provider is a priority for me because she's preterm labor and she needs to have a C-section if she's going to deliver. So I'm keeping that on my list. Prepare for emergency delivery. Prepare for emergency delivery is not something I'm willing to do right now. If it said prepare for possible, well, let me just say this. Prepare for emergency delivery is not my priority because she's preterm and because I have the option to notify the healthcare provider. And I'd rather the healthcare provider has to decide whether they're going to take her for delivery preterm. And it doesn't say prepare for possible C-section, and it's not a SATA. If it was a SATA, I would pick C, but I'm not comfortable with that being my priority because if I choose that, that means I'm not going to notify the healthcare provider. So I'm crossing C off. Administer tocolytic medications as prescribed. So I really like that because that's something. If we can stop preterm labor, we need to do that. She's 36 weeks. She's not full term. We need to stop labor. So I'm between A and D. If it was a SATA question, I'd be super happy, but it's not. I have to do one. So I say, what is my top priority? Notify the healthcare provider immediately, but don't administer tocolytic medications, or I'm going to administer tocolytic medications as prescribed, but not notify the healthcare provider. Y'all, I have to notify the healthcare provider. I have to do it. Now, I had somebody send me a message after I did some questions, and the right answer was notify the healthcare provider. And they said, I didn't have any questions on the NCLEX where the option was to notify the healthcare provider. And I say, fine, you didn't happen to. There are questions where the option would be to notify the healthcare provider. You didn't happen to get any of them. Fine. Remember, the right answer is the right answer because of the other answers. Okay. The right answer is the right answer because of the other answers. If notify the healthcare provider wasn't there, I would have picked D because that stops labor and it says as prescribed, right? So I would stop labor, try to stop labor before I would prepare for a C-section. That's what I would do in a preterm person. If she was 37, 38, 39, 40, I would be preparing for C-section. I wouldn't be trying to stop labor. I'm trying to stop labor because she's 36 weeks. So you have to pay attention to the words of the question. You have to pay attention to the other answers to decide what's your top priority. Which of the following signs would indicate that a client with placenta previa is experiencing hypovolemic shock? So low volume shock. Shock is when you're failing to perfuse your tissues. So what are some symptoms of failure to perfuse tissues? Well, your blood pressure goes down, you become pale, your urine output goes down, you change the level of consciousness, your urine output goes down, and you become tachycardic because the heart is trying to compensate for low perfusion. So the body stimulates the heart rate to go up, saying, hey, we got to get more blood out to the tissues. So those are the signs of hypovolemic shock. So hypertension and bradycardia, absolutely not. Those are the exact opposite of signs of shock. Tachycardia, yes, and hypotension, absolutely. Those are signs of shock. Decreased respiratory rate and warm skin. No, we have poor skin perfusion. You don't have warm skin. Poor tissue perfusion. You don't have warm skin. Increased urine output. These are all the opposite of what shock are. Every one of them, A, C, and D, are the opposite of what shock is. So make sure you know shock. I do have a video called Pressure and Perfusion, and it's an older video, so it doesn't get as many views as it did when it first came out. Maybe I'll redo something like that. Maybe I'll redo a shock video so people will watch it. But if you really don't understand shock, watch the Pressure and Perfusion video. Just type in pressure and perfusion clinic and it'll come up. That's it. So I hope that was helpful. Remember, painless placenta previa. The risk is bleeding. There's a risk for shock. C-section is the treatment of choice if they can't stop labor or control the bleeding. And corticosteroids mature the lungs of the baby. So I hope you have a great rest of your day. Thanks. Bye. Hello, Clinic Review families. Dr. Sharon with Clinic Reviews. We're continuing with the Blue Book today. We're going to be talking about endometriosis. The endometrium is the inner lining of the uterus, and we're going to talk about it when that inner lining somehow grows other places than where it's supposed to grow. That's endometriosis. So let's go ahead and get started. Hello, Clinic Review families. Dr. Sharon again here with Clinic Reviews. We're going to continue on with the Blue Book. I talked last time I did a Blue Book lecture. I did a menstruation in the ovarian cycle, and we talked about the endometrium. So I decided to follow up with endometriosis. The endometrium is that inner lining of the uterine wall. It grows and gets thicker. Well, it sloughs off at the beginning of the menstrual cycle or the ovarian cycle. And then it grows and gets thicker in response to estrogen. Once it's thick enough that can handle implantation, we see the egg is released and ovulation occurs. And then kind of the cycle goes back again if no implantation occurs. So we're going to talk about a disease of the endometrium, which is called endometriosis. As you know, this channel is a part of the Greater Clinic Review organization. We do the very best NCLEX reviews in the entire universe, in my opinion. You can find them on demand online if you go to clinicreviews.com. Mark Klimek, the GOAT himself, teaches those. It's very good. It's multiple lectures, 30-some lectures. It includes questions. It includes the yellow book. It's really good. We also offer a small group tutoring package that you can purchase. It's a month of small group tutoring, and they're also recorded, and you can watch them again after the fact, and you can even purchase just the recordings. I think you can do that. So we also have a streaming service, which is all the videos here on YouTube, plus some additional videos that you can watch with no commercials. It's under $20 a month to have access to every single one of those videos. Okay. Let's go ahead and get started with endometriosis. Remember, the endometrium is the inner lining of the uterine wall. Which of the following is the primary pathophysiological feature of endometriosis? Endometrial tissue forms polyps in the uterus. Endometrial tissue grows outside the uterine cavity. Uterine tissue becomes hypertrophic due to inflammation. Scar tissue replaces the endometrial lining. And the correct answer is either you know it or you don't know it. The endometrial tissue grows outside the uterine cavity. Y'all, if we knew why that happened, we'd all be rich and we could solve this problem and we'd have no more endometriosis. So I don't know why it happens. For some reason, endometrial tissue migrates outside of the uterus, attaches to other places in the abdominal cavity, and it causes problems. And just like the endometrial lining in the uterus, it grows in response to estrogen, and then it kind of stays thick for a few days, 2 weeks, while it's waiting for implantation. If no implantation occurs, it sloughs off and causes bleeding. And that's the problem with endometriosis. Imagine having endometrial cells somewhere else, attached to the kidneys, attached to the ovaries, attached to the bladder. It can cause a lot of pain, particularly when you're seeing that sloughing and bleeding somewhere else other than in the uterus. And it can also cause, kind of over time, it can cause scar tissue to form and some problems to occur. It's interesting. This is the same thing that happens with metastasized kidney cancer. Endometriosis is not cancer, y'all. Cancer is when you have cells that multiply, and as they multiply, they become less differentiated. Less differentiated means they look less and less like kidney cells. So if kidney cancer metastasizes somewhere else, it grows, but it also looks less and less like kidney cells. And that's what the difference is between like endometriosis and endometrial cancer that's metastasized, right? The endometrial tissue, if it's cancer and metastasizes, it looks less and less like endometrial tissue over time. But the interesting thing about kidney cancer that metastasizes is that it continues to filter drugs. So this is totally off the subject, y'all. This is why kidney cancer is so difficult to treat with chemotherapy, because the kidneys filter all these drugs. And so you try to treat kidney cancer with chemotherapy, and no matter where that kidney cell is, it filters that drug and it doesn't help, which is why kidney cancer is difficult to treat other than through surgical removal, radiation. I think there's some experimental treatments out there going on, but it's challenging to treat kidney cancer. A client with suspected endometriosis asks what diagnostic tests are commonly used, which test is considered the gold standard for diagnosing endometriosis: MRI scan, pelvic ultrasound, laparoscopy, pap smear. The gold standard is actually laparoscopy. Laparoscopy goes into the abdominal cavity and looks around with a camera. That's what a laparoscopy is. You actually have an incision in your abdomen, and you have a couple other incisions so that they can cut anything out that they need to, but you have a scope going in and they're looking around, and that's what they're doing. They're looking for endometrial cells. It doesn't sound like something easy to do. It sounds like they'd have to really know what they're looking for in order to be able to identify it. If you don't know this, when they do a laparoscopy, they actually insert air into the abdominal cavity and it blows the abdomen up so they have more room to look. And that's why the person feels so bloated when they come out of procedure after a laparoscopy. Which symptom is most commonly associated with endometriosis? Dysmenorrhea, painful bowel movements, fatigue, or hot flashes? The correct answer, which you probably can guess, is dysmenorrhea, painful menses. And so when you have bleeding other places other than just the uterus, it can cause a lot of abdominal pain. So dysmenorrhea means pain with menstruation. And so that bleeding is occurring other places than, it hurts enough as it is, right? Normally, because you've got the contracting uterus and it's contracting and having some issues and causing pain. But then you have that in addition to bleeding in other parts of the pelvis. And yeah, that's painful. When educating a client about the use of tampons during menstruation with endometriosis, the nurse should emphasize what? Tampons should not be used as they increase the risk of endometrial tissue spread. Tampons are safe to use with endometriosis if changed frequently. Tampons may increase the risk of pelvic infection and should be avoided. There's no difference in using tampons or pads for endometriosis management. So there is a difference between tampons and pads. Tampons are absolutely contraindicated with endometriosis, but endometriosis is not the kind of thing that you can spread. You don't spread it by the use of tampons. It just increases the risk of pelvic infection. Honestly, y'all, I don't know why. That's not intuitive to me to know why that is. I'm just telling you, it's a fact that you need to teach your patients. If you want to know why that is, go ahead and Google it. I don't know. I didn't Google it ahead of time, so I don't know exactly why that is. The nurse is teaching a client with endometriosis about hormonal therapy. Which medication used to manage endometriosis is an androgen derivative? So remember, the endometrial lining grows in response to estrogen. Okay, so if we can suppress estrogen, we can reduce the growth of that. So yes, it does impact fertility, but it's also going to reduce the pain associated with endometriosis. So androgen, you should know the word androgen. It's a male sex hormone, essentially. Androgens are male sex hormones. And there's a lot of different male sex hormones. Testosterone is one of those, but testosterone is not the androgen that we're going to give, okay? So if we were to guess here, estrogen is a female sex hormone, so we don't want to give that. It's actually going to stimulate the growth of the endometrial lining. Progesterone is a female sex hormone. It may not promote the growth of endometrial lining, but it's certainly not going to inhibit it. Clomiphene is actually used to treat infertility, so that's not an androgen. Danazol is the only one here that's an androgen. So do you need to know what all the others are for? Well, you certainly should know estrogen and progesterone are female sex hormones, and they're not androgens. Clomiphene, whether you know what that is or not, it's probably not necessary for you to know that. But danazol is the treatment of choice for endometriosis. It is a male sex hormone. It suppresses estrogen. So if you think about suppressing female sex hormones, what are the things that result from female sex hormones? Well, female sex hormones promote fertility. They increase the pitch of the voice. They somewhat prevent acne. So when you give someone an androgen, which is also considered a steroid, by the way, male sex hormones are what are used to promote muscle growth when people are weightlifting or in sports, and they're not legal most of the time because you have an increased, you have an advantage over everybody else if you're using male sex hormones, right? So you could have increased muscle mass if you're taking an androgen. So if you think about what are the side effects of danazol, should think, don't memorize them, but think what are male typical characteristic male traits that I would expect to see from a male sex hormone. A client with endometriosis asks how menopause might affect her condition. The nurse should explain. So with menopause, you no longer have ovulation, and as a result, you don't secrete progesterone as much, so you have a decrease in progesterone, and you also will see a drop in estrogen. So one of the things that leads to menopause, one of the things that takes women into menopause or premenopause is they start to have decreased levels of estrogen and other female sex hormones. So if you have decreased estrogen as a result of menopause, well, what's going to happen to the endometrial lining? You're not going to have much. It's not going to grow and slough off and grow and slough off every month. Okay, so think about that. So what happens with menopause? Symptoms may worsen. Well, that doesn't make sense. Endometriosis symptoms typically improve after menopause. That's true. Menopause has no effect on endometriosis. That's not true. Endometriosis is cured with menopause. So it's not cured. I wouldn't say it's cured because the person still technically has the diagnosis of endometriosis. What they don't have is they don't have the symptoms of endometriosis. So they may still have endometrial cells other places in their pelvis. They're just not having any symptoms because they're not growing and bleeding, right? So that's why endometriosis symptoms improve after menopause. What is the primary action of danazol in the treatment of endometriosis? Well, here we go. It suppresses the hypothalamic pituitary ovarian axis to decrease estrogen production. Well, that's a complicated answer. I know it decreases estrogen production, and it makes sense to me that it would be a hypothalamic pituitary ovarian axis. So I'm keeping that on the list. It promotes estrogen production. Absolutely not, because if you had increased estrogen production, you'd have worse endometriosis. It enhances progesterone activity to prevent ovulation. No, it doesn't. Androgens don't increase female sex hormones. It stimulates the endometrium to heal. No, it doesn't do that. So it just decreases estrogen production. That's what it does. A client is prescribed danazol for endometriosis management. Which of the following side effects should the nurse teach the client to report? So it's an androgen, which means you're going to look for stereotypical signs of male traits, masculine traits that you would expect. Weight loss. Yeah, I wish. Deepening of the voice. That's a characteristic male sex trait. Excessive menstrual bleeding, not an stereotypical masculine trait. Sudden headaches. I mean, you might get headaches. Any medication can cause headaches, but it's not sudden is the word that makes me think not, because you really shouldn't have sudden headaches. Headaches can result from just about anything, but sudden headaches makes me think no. So deepening of the voice is the characteristic male trait there that I would pick. A client with endometriosis has been experiencing dyspareunia. What does the nurse identify as the likely cause of this symptom? So before I read the answers, I need to know what this is talking about. So endometriosis, I say, well, they have endometriosis and now they're having dyspareunia. Don't know if I'm saying that right. That is painful intercourse. Okay, so you should know DYS is something painful or abnormal, right? If you didn't know what periunia is, you should know it. It's intercourse. So they're having painful intercourse. So I think, well, they specifically told me they have endometriosis. So I need to pay attention. So which one of these is most likely associated with the endometriosis? Inflammation of the fallopian tubes. I mean, they could have inflammation of the fallopian tubes, I suppose, but that doesn't seem like that would be the cause of painful intercourse. Low estrogen levels, no. Hormonal imbalance, no. Scar tissue adhesions in the pelvic area. That makes more sense. Out of all of these, even if I don't know that scar tissue and adhesions in the pelvic area can occur because of endometriosis, it's the only one that makes sense because I know none of the others make sense with endometriosis. And A, which could happen with endometriosis, I suppose, doesn't make sense to cause painful intercourse. So, and D, scar tissue and adhesions in the pelvic area is one of the reasons why infertility is a high risk for people with endometriosis. What is the effect of androgenic medications like danazol on the menstrual cycle of clients with endometriosis? It induces ovulation? No. It induces amenorrhea? It seems like it could, because if you lower estrogen levels, estrogen is one of the things that stimulates the ovarian cycle. It seems like it could cause amenorrhea. It increases progesterone levels. No. It stimulates regular menstruation. No, absolutely not. So the only one that makes any sense is that it could cause or induce amenorrhea. The nurse understands that endometriosis is primarily influenced by which of the following hormones: progesterone, androgens, estrogen, or thyroxine. I hope you know by now, after all the things we've talked about, that it's primarily influenced by estrogen. A 27-year-old female diagnosed with endometriosis expresses a desire to become a mother. Which of the following is the best nursing response? Endometriosis usually causes infertility. Well, that's true. Well, maybe not usually. It often does. Maybe not usually. Do not postpone pregnancy, as infertility is a complication of endometriosis. So I like that wording better. I don't want to say usually, because I wouldn't say usually, but it is a complication. And if she's saying I want to be a mother, I would be more likely to say, well, don't wait, because this is a possible complication. And that's because of the scarring and all that stuff that it can occur because of it. So I like B better than A. You should wait to attempt pregnancy until after treatment. Actually, that's not true. You should use birth control until you're ready to become pregnant. Maybe, but that's not related to endometriosis. We're specifically teaching her that infertility is a complication of endometriosis. So you probably don't want to wait too long before you try to get pregnant. All righty. Well, that's it. I hope that was helpful to you. And if you watched Menstruation in the Ovarian Cycle, these two videos really go together and complement each other to help you remember some of the hormones and so forth that are going on during the ovarian cycle. So I hope it was helpful to you and you better understand endometriosis. Love you guys. See you later. Have a great day. Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews. Today we're talking about menstruation in the ovarian cycle. So do you know when the follicle stimulating hormone is secreted? Do you know when the luteinizing hormone is secreted? Do you know when progesterone is at its highest level? If you don't know that, you might want to watch this video. Stay tuned. Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews. Today, I am continuing to work from the Blue Book. The Blue Book is right back there. You can see it. If you're interested in purchasing the Blue Book, you can purchase it on Amazon. Just search for the Blue Book. That's the name of it. And it's published by Mark Klimek. And you can also get it as an app, the Blue Book app. You could probably just Google Blue Book app, or you could go to clinicreviews.com and look for the Blue Book app there. It's a collection of facts that you need to know, just facts. It doesn't have any NCLEX style questions. I write these questions to go along with the book so that you can see how you can take the information in the Blue Book and use it in questions. So people will say to me, what do I need to know for the NCLEX? Well, part of what you need to know is in the Blue Book. Okay. So, we're part of the greater Clinic Review organization. We do NCLEX reviews on demand. You can get those through clinicreviews.com. You can also do our on-demand tutoring. It comes in, monthly tutoring, small group tutoring comes in a monthly bundle. And then we also have, our streaming service. Okay. So let's go ahead and get started with the questions. What is the average amount of blood loss during a menstrual period? 10 to 20, 30 to 40, 50 to 70, or 100 to 150. So the answer, you just know it or you don't. It's actually, the Blue Book says 50 to 60. I would say it would be right anywhere between 50 to 70 or 50 to 80. I wouldn't go much over 80. I wouldn't go much below 50. That's a pretty good average amount. Which phase of the ovarian cycle begins with the maturation of follicles and ends with ovulation? So what we're going to do today is we're going to be asking the same questions over and over again, but they're going to be worded differently so that you know how to answer these questions. I don't know about you. I'm not an expert on this. So for me to remember what is secreted when and all the different phases can get confusing to me. So I have to practice it. I have to talk about it, talk through it. So that's what we're going to do. So the typical menstrual cycle is 28 days, not the menstrual cycle, but the ovarian cycle is 28 days. Whether your cycle is 30, whether your cycle is 32, whether your cycle is 27, on the NCLEX, you're going to say it's 28 days, okay? So the first 14, they're divided into two 14-day segments. The first 14 days is called the follicular phase. It starts with menstruation, so that's the shedding of the uterine lining, starts with menstruation, and it ends with ovulation. Then the second 14 days is called the luteal phase that begins with ovulation and it ends at the beginning of menstruation. So the first day of the menstrual period is the first day of the cycle, okay? So which phase of the ovarian cycle begins with the maturation of follicles and ends with ovulation? That's the follicular phase. We have two phases, the follicular and the luteal phase. All right, how many days after ovulation does menstruation typically occur? So ovulation occurs on day 14. Day 1 is menstruation, the first day of menstruation. Day 14 is ovulation. Then there's 14 more days before menstruation occurs. So how many days after ovulation does menstruation typically occur? It's 14 days. Which hormone is primarily responsible for the stimulation of ovulation? Now, this is where things can get a little bit confusing. So we have the follicular phase. During the follicular phase, we have estrogen levels rising. Estrogen levels, as they go up, stimulate the thickening of the endometrial layer. The endometrial layer is essentially the lining of the uterus, and it gets thicker and thicker because it needs to be thick enough for implantation of the fertilized egg. So estrogen levels go up during the follicular phase, and that endometrial layer gets thicker. The other hormone that goes up is the follicle stimulating hormone. So what happens is we have a follicle, and the follicle matures, and it eventually matures to where it's ready to release an egg. And when it releases that egg, that's called ovulation. So we have follicular development and ovulation, that's day 14. We have, after menstruation is done, we have increasing thickening of the endometrial lining, and that's estrogen that stimulates that. So what hormone is primarily responsible for the stimulation of ovulation? All right, it's none of the ones I just told you, y'all. So I just told you the follicle stimulating hormone matures the follicle. Estrogen increases the thickness of the endometrial lining, but then there's another hormone that stimulates the release of the egg itself, and that's the luteinizing hormone. And that's pretty much the only role of the luteinizing hormone. So luteinizing hormone has like one job, and it stimulates the release of the egg from the follicle. The follicle stimulating hormone matures the follicle, so it's ready to secrete the egg. Estrogen thickens the endometrial lining, so it's almost ready to take an implanted egg, but it's the luteinizing hormone that stimulates the release of the egg from the follicle, which is ovulation. What is the main hormone during the follicular phase, or what are the main hormones during the follicular phase of the ovarian cycle? So I just told you that, y'all. Do you remember what I told you? And it's not luteinizing hormone. Luteinizing hormone peaks right with ovulation because that's its only job. But it's not really out there any other time. So what are the two? I told you have one that stimulates the maturity of the follicle, and you have one that stimulates the thickening of the endometrial lining, and that's estrogen and FSH. What is the main role of progesterone during the luteal phase? Okay, so we have the follicular phase that ends with ovulation. Once the egg is released, the releasing of the egg stimulates the creation of what's called the corpus luteum. The corpus luteum is a cell layer along the top of the endometrium. So estrogen has promoted the growth of the endometrium. So we've got the endometrial lining that's nice and thick and it's ready for an egg, but then we need something else on top of it. And what it goes along the top of it is the corpus luteum. That occurs as a result of the release of the egg. Once the corpus luteum is in place, it starts to secrete another hormone, and the hormone it secretes maintains the corpus luteum. So the corpus luteum secretes a hormone to maintain itself. All right, what is the main role of progesterone during the luteal phase? It prepares the endometrium for possible implantation. So in other words, it maintains the corpus luteum. Okay, so the endometrial lining is covered by the corpus luteum, and progesterone maintains it. Okay, so that's the main role of progesterone. which hormone is primarily involved in the thickening of the endometrium during the proliferative phase of the menstrual cycle. So I told you, and this is why we're using different words so you know how to answer these questions. We have the follicular phase and the luteal phase. The follicular phase starts with menstruation, ends with ovulation. The luteal phase starts with ovulation, ends with menstruation. So what is the proliferative phase? The proliferative phase is another word used for the follicular phase. The follicular phase is the entire phase. The beginning of the follicular phase, you have menstruation. That's where you shed the endometrial lining. Once that is shed, then you begin to proliferate the endometrial lining again. So you shed it, and then it starts to grow again. So this is now the second half of the follicular phase, could also be called the proliferative phase. So what hormone is involved in the thickening of that during the proliferative phase? And I told you what that was, because I told you the FSH matures the follicle, but I said something else thickens the endometrium, and I said it's estrogen. So it's estrogen that's responsible for thickening the endometrium